Good evening to everybody who has joined in for this webinar. A sad news before we start. We have an obituary. One of our senior members, Professor Ambasta, who was the past director of the Indira Gandhi Institute of Medical Sciences at Patna, expired, and he was aged, but he was a very senior member who has contributed significantly. He was a council member of the Urological Society of India, has immensely contributed for development of urology in the East Zone. So uh, I would request all of them for a 30-second mourning and we have sent a condolence message to his family. I've spoken to his family also. A 30-second mourning from all the members who are present there now. Thank you, gentlemen. Welcome to the Pediatric Urology Subspeciality webinar. This is the finals of the competition which we had, the interzonal. There were 24 teams which participated, of which we have selected 8 teams. And today all these 8 teams would be competing for the prizes which are in stake for them. And this is being moderated by Anil Takwani. I would also welcome the international faculty, Dr. Paul, Dr. Pramod Reddy, and Dr. Luis Braga, and the guest faculty, Dr. Venugopal and Dr. Sabnis, and the expert panelists are Professor Anant Kumar, Professor Hemant Patak, Professor D. Ramesh, Dr. Chandra Singh, and Dr. Rajiv TP. And with this, I would hand it over. I would ask our president, Dr. C. Mallikarjuna, to give his opening remarks, and then we move on to the session. Over to you, Dr. Mallikarjuna.
Thank you, Keshav, and good evening, gentlemen and ladies and gentlemen. But anyway, this is a fantastic program which has been conducted by Anil Takwani, a different sort of variety which has gone through in the last year and this year too. And we have come to the finals of this pediatric urology competition. I wish all the best to the contestants, and I hope we have a great program. I understand we need to be praying for all our country members who are going through a devastated period for COVID, which is happening in our country. We stay ourselves safe and possibly protect the country also and the countrymen also. We include their names in our prayers so that all the country people are going to be healthy and stay safe from COVID. Go ahead, Keshav. I think we'll go ahead with the program. I don't think there is nothing to jubilate about in present day in this country today, but we all will stay safe together.
Thank you, Dr. Mallikarjun. Now I would invite Professor Rajiv Sood, Chairman of the ISU, for his remarks. Over to you, Dr. Rajiv Sood.
Thank you, Dr. Keshav. This is a great occasion today, the culmination of this competition. And as we know that in any educational program, which has been now propagated by University Grant Commission also and National Medical Commission also, that awards and rewards should be there integrated into the curriculum and the course of the education, wherever these educational institutes are there. On the same line, I'm happy that the pediatric subspecialty has given such a wonderful program and involving all the 4 zones, creating the sense of competition and also culminating in awards and reward, which is going to happen today, and studied with the star faculty, national and international, with the eminent teachers. We all have gathered on this platform, and this is also unique in this virtual era of education, that all these stalwarts in one platform we can see and interact also. The teams 8 which are going to participate today with the well-crafted program by Dr. Anil Takwani and the pediatric subspecialty, along with my co-chair, Dr. Arun Chawla. I welcome all of the 8 teams of 4 zones and wish good luck to all of them. And with this, I hand it over back to Dr. Keshav.
Thank you, Professor Sood. It's now time to hand it over to Dr. Anil Takwani to conduct the proceedings. Over to you, Dr. Anil.
Thank you very much, Dr. Keshav Murthy. Before I begin, I just wanted to check whether Dr. Paul has joined or not, because he was also inquiring for this USI membership. I told him.
Dr. Paul is there.
Yeah,
Dr. Paul is there.
Yes, sir. So you are very much there, sir. Thank you. Sir, you unmute. Sorry, sir, you mute yourself. Dr. Paul.
Yes.
Yeah. Good morning to you. And for a while,
Good
sir,
morning.
you mute your speaker, sir. Okay, thank you. So it's rightly said by our president. I would like to dedicate this webinar to our frontline warrior, that our presenters. They are most of those are not only working in Department of Urology, but they are having a very periodic duties in the COVID. And we definitely would like to dedicate this particular final webinar, to those our urology residents and all residents, those who are working day in, day out for COVID patients. And again, I agree with him that we will not be having a celebration, nothing too jubilant, but so must go on. As he said, what we learn in the medicine, that's the reason that we are here, and will not leave any stone unturned for in presenting our work, the experts, to the viewers, and to the international experts. Good evening and good morning to all our international experts. Thank you once again, USI and ISU, for this opportunity given to Pediatric Urology Subspecialty. On behalf of our entire team of Pediatric Urology, we are extending our warm welcome to all of you in this extremely exciting and popular student and mentors webinar on theme how we do pediatric urology at our institute. Friends, in this unprecedented testing time, we have learned lesson of the strength to tackle the situation and courage to help. As Dalai Lama has rightly said, we need oneness among the 7 billion people living in this world. And probably outcome of this pandemic, we will melt our egos, and only brotherhood beyond the boundaries and humility will remain our ethos. For the present, now coming to the format of this competition, we are all knowing 6 minutes for the presenters and 4 minutes for the question and answer. And please stick to this time. If you will exceed the presentation time, it will be going against your markings. For experts, please, I'm requesting all experts, national and international. It's a request that please ask very short and precise question, and at a time you ask 1 or 2 questions, so second expert can get the equal opportunity to interact with our presenters. And please do not waste that 4 minutes of presenters in making observations and comments. We'll definitely give some time to listen your observations and comments, because you are most esteemed specialists or faculties, and we will cherish to interact with you. And those who we can that can be done after the closure of presentation. And we have with us Professor Venugopal, who is a teacher of our teachers, as he has taught 3 generations of urology. Sir, thank you for joining and for your blessings. We have our president-elect, Dr. Shabnish, head of the urology department. I don't know whether he's joined or not, and all of you are knowing, so no introduction. Our international experts are Dr. Paul Marguren. He is a head of pediatric urology, professor at this Seattle University, Children's University, very prestigious, and we'll ask him to share the couple of regarding his journey and couple of his thoughts. We have a Pramod Reddy, once again joined from the Cincinnati Children's Hospital, USA, and we have a Dr. Luis Braga from McMaster University. They were with us in previous episodes in the second series. We have our own experts Dr. D. Ramesh, who is professor and head at urology department at Ramaya Hospital, Bengaluru. We have a Professor Anand Kumar, past president and ex-chief of prestigious SGPGI Lucknow. And we have a Professor Hemant Pathak, a lovely-hearted teacher from Nair Hospital, Mumbai. And we also have Rajiv PP, sir, our ex-immediate past secretary, joined from the Guwahati. And last but not least, Professor Chandra Singh, our dear friend, young and dynamic urologist from the CMC Vellore. So we have a very excellent, brilliant minds to interact with our speakers. And all of, for us, all 23 presenters, see, you have 5 independent judges. So the ranks are not in anyone's hand, and they are independently going to send their markings to the Kesamurthy sir, right? And he will compile and he will declare the results. For us, and my president and secretary will agree with ISU office bearer that all of you are winner. All 23 presenters and mentors are winner. Our aim at the beginning, where and secretary also will agree at the end that we wanted to give opportunity to showcase the skills in field of pediatric urology across the country. And secondly, definitely we would like to improve from here and in our understanding and management of most fragile urological patient community, that is pediatric urology. On behalf of, again, Pediatric Urology Subspeciality Committee, is Dr. Malikarjun, Dr. Banerjee, Dr. Chatterjee, Dr. Prasanna, and Dr. Rahul Kapoor. I thank you, all the presenters, and congratulate them to be presenting. For all of us, you are winners. And with these words, we are beginning our first presentation with the permission from the Secretary Kesamurthy sir. Can I go ahead?
Yeah, please go ahead, Anil.
Okay, so we have already allotted the lottery system, and our first presentation today's evening is that is Dr. Kamal Sachdeva from NU Hospital, Bengaluru, and he is presenting on pyeloplasty in poorly functioning kidney, and is mentored by Dr. Kumar Prabhu. So, Dr. Kamal, you share your screen. Rahul, you will maintain the timings.
Yes,
6
sir.
minutes for presentation, 5 minutes, you will give a warning.
Yes, sir.
Can you see my screen?
Yeah, you can start your presentation. Your time starts now, Kamal.
Good evening. Thank you, esteemed USA members and international faculty, for giving me an opportunity. Outcomes of pyeloplasty in unilateral poor function kidney are debatable. We present our data of pyeloplasty in a poorly functioning kidney in a pediatric age group. Despite good understanding for PUG obstruction, there is no standard definition or cutoff for intervening in a poorly functioning kidney. There are no established guidelines for timings of surgery, recovery, or regarding duration of follow-up after pediatric pyeloplasty. All these studies support pyeloplasty with or without nephrostomy in poorly functioning kidneys. They had reported significantly improvement even in less than 10% of differential renal function. We have analyzed 12 years of retrospective data of children with unilateral PUG obstruction with GFR of less than 30 ml per minute or differential renal function of less than 30 who underwent dismembered pyeloplasty, further followed up by ultrasound at 3 months and DTP at 1 year. We excluded all this criteria and had totally 31 children of mean age 4 years. If the condition is diagnosed antenatally and the parents follow up postnatally with us, we advise diuretic renal function to confirm the PUG obstruction after 8 weeks. We operate in this infant in 3 months of age or 5 months, whichever is early. We evaluate post-operatively ultrasound parameters at 3 months and diuretic renogram to look for relief of obstruction, differential renal function, and improvement in GFR. After 1 year of surgery, in my study, all came significant. All these parameters were correlating with the high correlation with maximum correlation with parenchymal thickness was noted. We divided our data into 3 groups. 26 children were in DRF of 11 to 30%, 4 in 1 to 10%, and 1 child had 0% differential renal function. Initially, DRF function in a group of 1 to 10% function group, we noted better increase in mean GFR and parenchymal thickness. We operated a child with 0 function and 0 differential renal function, and after surgery we did not find any improvement in renal function in spite being a symptomatic relief. The child is doing well until now. After 4 years of surgery, no intervention has been done. At 1 year, out of 31, we found improvement in 29 children. No change in the one which I told earlier, and worsened deterioration of the renal function from 25% to 15% in one child, in spite of improvement in drainage, as we believe it was overestimated pre-op DTPA. Differential renal function is not an exact tool for follow-up in a reduced renal function, due to the deteriorated renal function of operated kidney or contralateral compensation. Going back to Stock et al. In 1995, who gave reason of no improvement despite pyeloplasty by performing renal biopsy, which reported tubular atrophy and glomerulosclerosis were the main reason for no improvement. Chandrasekharan noted, in spite being improvement in renal function till 5 years, maximum or significant change were within the first year of surgery. Then Paul et al. And Soy in 2003 reported no obstruction
Dr. Kamal, last 1 minute.
And no obstruction in 3 months on DTPA in around 85% of patients, and there was no significant change on the second renogram. I would like to correlate 2 studies in Ansari et al. And Wagner et al. Performed even in 0 function kidney and reported increase up to 25% and 45% respectively, after followed by the prior temporary diversion, and later pyeloplasty was performed. But we didn't do PCN insertion before doing a pyeloplasty in a 0% function child. My take-home message is that less than 30% differential renal function is labeled as poor function kidney, and pyeloplasty gives better functional and structural outcome in a very poor function kidney, that is less than 10% of differential renal function. And on follow-up, diuretic renogram at 1 year is sufficient to assess the success of the surgery. Thank you.
Thank you very much, Kamal, for your presentation. You stop sharing. Your question answer time starts now. I have one very quick question. Have you given any importance to improvement in cortical thickness and pelvic diameter? At say
Yes, sir.
3 months, 6 months, 1 year, like that.
Yes, sir. Of course, parenchymal thickness has an importance, sir. as well as cortical.
Any idea about the improvement in the cortex and the pelvis and that ratio, which is having any role in the determining the outcome?
Sir, there is one role of cortical transient time when we doing conservative and
I'm asking about the sonography findings. So no way, no problem. We go ahead with the Dr. Baga. Dr. Baga yesterday only operated a similar sort of cases. Okay, and go ahead with your precise question, Luis.
Thank you. Great presentation. So my question would be, did you find any specific factor that I would, at least when you did the operative findings, that would allow you to identify those kidneys? Why would they have like those very low differential renal function? So what I mean is that you look at the parenchymal thinning, you look at the AP diameter, but sometimes some patients may have an intrarenal pelvis, and then I believe that there is more pressure, or those kidneys are less compliant. So maybe the parenchyma will suffer like a bigger hit.
Luis,
so
I request you for question. Yeah. Luis.
Yes. So did you find any correlation between patients who had lower function with maybe less or a reduced AP diameter intrarenal pelvis as compared to those with redundant pelvis compliant, and because you saw an improvement in the parenchymal thickness?
Sir, of course, the patients having good parenchymal thickness had good improvement, and while decompressing in a very poorly functioning kidney, when we noted there is a loss of reniform shape of the kidney and the papery thin parenchyma, in such kidneys, sir, improvement will be very less. Introply, we can judge that, sir.
And
very quick question from Professor Anand Kumar. Luis, very quick question from Professor Anand Kumar. Sir, unmute yourself, sir, please.
Yes, so a quick one
Sir,
would be...
Yeah, Anand Kumar, go ahead with your question.
Oh.
Yeah, my question is, once the GFR drops to less than 10, then it is labeled end-stage renal failure. And we have seen these kidneys never improves, but I'm surprised to see that your patients have improved even if they have GFR less than 10. And I also like to know how the thickness has improved because when the patient loses, it is replaced with the fibrosis and glomerulosclerosis. And then it is theoretically not possible the thickness to increase. So how can you explain these two things?
Sir, early presentation and early surgery to patients had more good outcomes, sir, rather than asymptomatic at presenting at later age group, sir.
Infancy, if we operate, we find there is a definitely good improvement. As even in the literature also, those children who have operated in the early age group, there is definite recovery. As in Ansari's paper also, there's up to 25% improvement in GFR.
Okay, very quick question from Hemant Pathak.
Yeah, see, you have divided it into three groups. One is 15 to 30, and second group. But how much was in this subgroup? Was there any correlation between group 2 and improvement and group 3 and improvement? And what was the percentage of improvement? You have only specified there was improvement. There was improvement. But what was the percentage of improvement?
Sir,
and how did you gauge that improvement?
In the group, sir, less than 10%, including 0%, 4 out of 5 improved, sir. And there was more room of improvement in the group between 11 to 1 to 10% as compared to 11 to 30%, sir.
Can I ask a quick question? What was the age?
Luis, Rahul, how much time is left? Unmute yourself.
Sir, we can accommodate the last question.
Question, Luis.
So what was the age that you guys observed the highest degree of improvement? Because when you say early, was in babies younger than 6 months, 3 months, or a year?
Sir, less than 1 year of age group had more improvement, sir.
Thank you.
Okay.
Thank you, sir.
Fine. So
sir, time over.
Yeah. So thank you very much to remain in the time. And I once again request all experts to please try to make question very precise because in this particular contest we are helpless because we cannot extend the timing for question and answer. Otherwise, we'll not be accommodate all 8 presentations and couple of interactions with you all excellent faculties. So before we move to the second presentation, I would like to welcome Pramod Reddy, who has joined already from the Cincinnati. Pramod, good morning to you.
Morning.
Very warm welcome. This is Dr. Paul. Please unmute yourself, sir. This is regarding. We would like to request you, sir, Dr. Paul. We would like to request you to share your journey in field of pediatric urology. One, second, we would like to know that right now you are working, taking the treatment protocol standardization because there is a lot of variations in the treatment of pediatric urological conditions. And thirdly, we would like to have a very short comment on some inspiration which you received from your very good friend, Dr. Richard Geddy, who passed because of malignancy. So we have 4 minutes for you, sir. So go ahead, sir. We would like to have some inspiration from you.
Good morning, everyone. First of all, my prayers are with everyone in India in this terrible pandemic where all of you have been converted in like a week from urologists and surgeons to COVID experts. Especially my extended family in Ahmedabad that I've been talking about my journey. It's interesting, my journey and Dr. Reddy's journey are pretty close to each other. I trained at the University of Rochester. Actually, I grew up in Israel and did my medical school in Israel and then did 3 years of general surgery residency before moving to the United States, where I completed my urology residency at the University of Rochester in Rochester, New York, and then my fellowship at the Hospital for Sick Children in Toronto. I was on staff in Toronto for around 4 years and spent most of my time in New England at Dartmouth College for approximately 15 years, and I've been at Seattle Children's for the last 11 years. I'm the chief of urology at Seattle Children's Hospital and also professor of urology at the University of Washington. What actually inspired me into, and we all have mentors. My mentor was a pediatric urologist in Rochester, Ron Rabinowitz. He was the one who actually got me interested in pediatric urology, and I've never been happier. I think that I chose the right profession. It's a profession that I enjoy working on. My work mostly involves in quality improvement and efficiency. So really looking at standardizing the way we do things. Currently, we're working on standardizing the way we document hypospadias repair. Not every hypospadias is the same, really looking at the same type of operative reports, the photographic pictures that are embedded into the electronic health records, how we take pictures, how we document, all these things, so that eventually when we're looking at outcomes, we can compare apples with apples. The other thing that we're also working on is trying to get best practices and really joining with other institutions around the state of Washington to collect data and possibly also videotape surgeons operating so that we can actually find best practices and duplicate best practices. I've been involved.
About Dr. Grady.
Yeah, my interests are in reconstruction and bladder exstrophy, and I joined Seattle Children's 11 years ago. Dr. Grady was there. Dr. Grady, it was an inspiration to me. He was a friend. He was someone who I would call was a saint. He never thought of himself, but his motto and his way of life was to help people in underserved regions, no matter what. I mean, he would travel to the Gaza Strip, which is a dangerous place in the Palestinian territories, and stay there for a couple of weeks, or to Mozambique in Africa. And then he started the urology, the bladder exophy workshops with Asim Shukla in Ahmedabad. And I wish he was there to see how that workshop has increased and become an international workshop. People from all over the world come into that workshop on a yearly basis to see experts operate on bladder exophy. I can't say enough about Dr. Grady. He was, to me, was an total inspiration. Thanks.
Thank you very much for your sharing your inspirational journey and sharing your inspirations. We also missing very much Dr. Grady. I had a couple of opportunity to interact with him, specifically at the Delhi conference. He was one of the expert panelists. So with that, we'll move to the second presentation today evening. That is from Dr. Dhruv Patel. Is from IKDRC Ahmedabad. Is going to speak on the robotic assisted laparoscopic kidney transplantation in children. He's mentored by Dr. Suresh Kumar. So share your screen, Dr. Dhruv. Dr. Dhruv, you unmute yourself.
Yes, sir. I have unmuted and my screen is visible.
Multiple things are visible. Yeah, okay. Full screen now.
Okay.
Okay, so, fine. Go ahead. Your time starts now.
Okay. Okay, sir. Very good evening to all of you, USI members and international faculties, and my dear colleagues. Thank you for the opportunity to present robotic assisted laparoscopic kidney transplantation in children under the mentorship of Dr. Suresh Kumar from IKDRC. Kidney transplantation is a standard of care in pediatric patients suffering from end-stage renal disease, with advantages of quality of life, growth, and the schooling. It also provides greater survival as compared to the patients on hemodialysis. But there are many issues in the pediatric open kidney transplantations, like scarred abdomen due to previous urological surgery, and the size disparity between the graft size and the abdomen, which leads to potential threats for the compartment syndrome. Sometimes large incision as compared to the body size, which leads to disfigurement, especially in the teenage patient. And small children many of times require transperitoneal approach for exposure to the larger caliber vessels, which leads to prolonged exposure of the abdominal cavity to environment. To overcome these issues, and with the experience of multi-institutional trial held at our institute, for adult robotic kidney transplantation and showing good result, so permission from the ethics committee was granted, and we conduct prospective non-randomized open label trial comparing open versus robotic assisted laparoscopic kidney transplantation in children between the age of 6 to 18 years. In robotic transplantation, patient was placed in the supine with 30-degree Trendelenburg position, and pneumoperitoneum was kept at 10 to 12 millimeter of mercury. After releasing of the clamps, we generally reduced pneumoperitoneum to less than 5 mm of mercury for better perfusion of the graft. And for intraoperative monitoring of the hemodynamics, central venous line and arterial lines were taken. This figure showing the port placement. This is the 12 mm camera port, 3 working port of 8 mm, and 1 12 mm assistant port. And here is the 7 mm phalangeal incision for the graft insertion. After docking of the robot, external iliac vessels or sometimes common iliac vessels were dissected, and vascular anastomosis were carried out as per shown in this figure. The uretic reimplantation was carried out with modified Lis-Gregor technique as per shown in this figure. And this is the photograph showing post-operative good cosmetic outcome in pediatric patient in robotic transplant. In the results, in this prospective trial from 2013 to 2021, total 62 patients were enrolled in the robotic group and 22 patients were enrolled in the open transplantation group. The demographic data in the form of mean age, weight and the male-female ratio were comparable in both of these groups. The donor characteristics also comparable in both of these groups, with mother is the most common donor in both of these groups. And we have also done robotic transplantation with right kidney in 7 patients and kidney with multiple renal artery in 10 patients. The primary etiology were comparable in both of these groups, with dysplastic kidney were most common in the robotic group of the patients. While comparing the intraoperative data, no statistically significant difference was observed in the cold ischemia time, vascular anastomosis time, and the total operative time. But ureteric reimplantation time and intraoperative blood loss were significantly less in robotic group as compared to the open transplantation. For comparing the trend of serum creatinine, pre-transplant serum creatinine was comparable in both of these groups, while on day first, statistically significant lower serum creatinine was observed in robotic group, but subsequently at day 7, at 1 month, and at 6 months and 1 year, the serum creatinine level were comparable in both of these groups. At 95 months of follow-up in open group, 1 patient were expired and had survival probability of 95.5%, while 5 patients were died in robotic group with survival probability of 91.9%, and the Kaplan-Meier curve of both of these groups showing no statistically significant difference. For death-censored graft survival, 81.8% graft survival was observed in open group, while robotic group, it was observed as 83.9%, and the Kaplan-Meier curve of the graft survival showing no statistically significant difference in both of these groups for graft survival. In summary, robotic kidney transplantation in pediatric patient is technically safe and feasible in the hands of experienced robotic surgeon. No vascular or the urological complications were noted in our series, and robotic kidney transplantation is patient-friendly. My take-home message will be robotic kidney transplantation has potentiality to replace open kidney transplantation, especially in children, and larger multi-institutional prospective randomized trial is required to understand the benefits of the robotic kidney transplantation in children. Thank you for the presentation.
Thank you, Dr. Dhruv, for your presentation.
Yes, sir.
And your question and answer time starts now. Do we have Dr. Mallikarjun? No. Then Dr. Anand Kumar, you raise your first question, sir. Please be precise, sir. Go ahead, sir.
Yeah. My question is, yeah, I agree that this is a good modality. We have also done few cases. But my question is, did you find any difficulty in placing the kidney back to the extraperitoneally, because sometimes kidney always comes from the parents and kidney size is quite the extraperitoneal space you create in children is less limited. So sometimes did you have difficulty in keeping there or suturing it, keeping it somewhere?
Yes, we generally do intraperitoneal approach, and after completion of anastomosis, we flip the kidney to extraperitoneal, and the peritoneal wings were closed with the clips. And if there is disparity, sometimes we left open, and sometimes we left the kidney intraperitoneally also, if there is difficulty in closing the peritoneum.
And another question, can you explain why the robotic ureteroneocystostomy was shorter than open? Because in open, when we do surgery, everything is already prepared. We just take and join it. So I think the open is quite faster than the robotic. I'm just wondering why it is so.
Because the robotic transplantation was done by the single experienced surgeon, and open transplantation were done by multiple surgeons. That might be the cause for the difference.
Okay, Dr. Venugopal, sir, go ahead with your question, sir.
I have only one doubt I have got.
Yes, sir.
The number of cases in robotic group is around 40 or 45, whereas in open is 22. Why is this disparity?
Yes, robotic. No,
Was
sir.
it biased for robotic and most of the patients were taken for robotic?
No, sir. This trial was open label. We have given choice to the parents that you have two options, open and robotic, and the patient will decide, because this was open label trial, non-randomized trial. That's why I said at the last that prospective randomized trial is required to confirm the results and for the better outcome.
Okay. Pramod, you would like to answer a question? You can ask.
I think that definitely pushing the technology is wonderful, and Dhruv, great presentation, wonderful effort,
Yes.
and nicely designed study. So I
Thank you, sir.
on that. I think that, as we push the envelope of minimally invasive, we always have to make sure that we're not using a tool where it may not have the real benefit. So do you think that the operative time is higher with the robot, and is that going to impact the longer term outcome of the kidney graft?
No, the total operative time were comparable in both of these group in our study, and the anastomotic time were also comparable. So it will not affect on the post-operative outcome.
Do you have data to suggest that, or is that just is that just your opinion? Do you have creatinine data to suggest that there's no difference?
Yes, there is no difference.
Okay, and 1 year and 5 year, there's no. I don't know.
No difference.
Yep, no difference.
Yes, sir.
Excellent. Thank you.
Yes, in graft survival and
question.
patient survival also no difference, sir.
Okay, quick question, last question from Dr. Ansari.
Yes, I just wonder, Dhruv, you said that this should be the standard of care for future and children, but you did not show in what way it is beneficial as compared to the open.
Yes.
Graft survival is same, rather the death of the patient is more in the robotic arm.
But that was the more because the 62 patients were in the robotic and only 22 patients were in open transplant. So, but statistically analysis shows there is no statistically significant difference for this difference. It's only observed difference. Statistically, it is not significant. And for the future, the robotic transplantation will benefit in the form of the better cosmetic to the patient, less pain, and less scar to the patient.
It affords all the advantage of minimally invasive surgery in children, particularly in children. That is the main advantage. And the graft and the patient survival outcome are similar to the open kidney transplants.
Rahul, do we have a time?
Time over.
Time over. Okay, thank you, Dhruv, for your
Yes,
precise presentation and the questions. So before we move to the next presentation, we can have Dr. Ramesh we have with us. Dr. Ramesh, are you still? Dr. Ramesh, you are there?
Yes.
Yeah. So you had been secretary and you pioneered a couple of things. What do you think regarding the pediatric urology? How far we have progressed from where you have observed?
Yeah, I've been seeing the growth of pediatric urology right since when I was a resident. And there were a few urologists who are very passionate. Dr. Venugopal, who's here with us today, Dr. Shyam Joshi. The number of people who used to attend the pediatric urology session used to be just a handful. But the energy these seniors put into the growth of pediatric urology in the country has been phenomenal. And it evolved, the subspecialty groups evolved slowly. And in the last decade or so, there has been a tremendous enthusiasm and growth. And the current generation of teachers, a few of them have taken up pediatric urology, like Professor Ansari from SGPGI Lucknow and others. You yourself in the private sector are doing phenomenal work in pediatric urology. And happy to note that the Cincinnati group has supported the pediatric urology fellowship program under the leadership of Dr. Pramod Reddy. It was initiated when I was the secretary of USI, and USI has built up great bridges with the Cincinnati Hospital for promoting pediatric urology enthusiasm among the youngsters. So we should be grateful to them, and people like you have taken this to a good front.
Thank you very much. Pramod, would you like to reciprocate these comments? You unmute yourself.
Thank you very much. It's a privilege and an honor for me to be able to join all of my esteemed colleagues in these events, and I salute you, all of you, because you're doing a phenomenal job. And I also want to echo Dr. Magurian's concerns. My wife, my family, we're just watching the news coming out of India, and our hearts are broken to see what's happening right now in India. And we're just praying every day that God will lift the darkness and allow a new dawn to come forth where people are back to being healthy and we're not seeing this devastation of our citizens back there. And I also salute all of you for the work that you continue to do every day, taking care of patients and making sure that the delivery of healthcare to these patients is going unscathed and continuous. You're putting yourselves at risk and working tirelessly. I was talking to Dr. Joshi at Civil. You guys are sleeping like 3-4 hours a day, and this has been going on for the past year. So you guys are really healthcare heroes and doing a phenomenal job every day. Anything that I can do, and I know I speak for Dr. Braga, Dr. Magarian, and all of the team members that come to India every year, it is our privilege to help and partner and learn, because it is a two-way street. We're learning from you just as much as we're helping you. So this is a phenomenal collaboration between our colleagues in North America and in India. And please know that we are fully committed to doing anything we can to continue this growth and development of pediatric urology as a subspecialty within India. So thank you very much for this opportunity.
Thank you very much, Pramod, for this precise in response to the comment from Dr. Ramesh. So we move to the third presentation today. Is from SGPGI Lucknow. Dr. Jain Tamboli is going to present on upfront ureterocalycostomy, decision-making in primary and recurrent ureterocollic junction obstruction. He is going to be mentored by Dr. Utsav Sailesa. Your time starts now, Zain. Right.
Good evening, esteemed judges. My name is Dr. Zain Tamboli, and me, along with my mentor, Dr. Utsav Shah, from the Department of Pediatric Urology from SGPGIMS Lucknow, will be presenting today on upfront ureterocalycostomy, a decision-making in primary and recurrent ureteropelvic junction obstruction. We do not have any disclosures to make. So coming to the topic, the classical indications for ureterocalycostomy are a failed pyeloplasty, PUJO with renal anomalies like horseshoe kidney, traumatic avulsion of the renal pelvis for the upper ureter, long segment upper ureteric strictures, repeated surgeries for stones, and nephron sparing surgeries for RCC and PCC. But the patients presenting to us most commonly present with this indication of giant hydronephrosis. So giant hydronephrosis, according to literature, is defined as that occupying 5 or more vertebrae or reaching or crossing midline when the contents of the sac are more than the daily urine output for age, when the 2 to 4% of the body weight is in the sac. So coming to a case-by-case scenario, in this first case, we can see that there is bilateral hydronephrosis, which can be easily managed with bilateral pyeloplasty. But what about this case, in which there is a hugely dilated renal system, grossly thinned out renal parenchyma, and distorted renal architecture? And in this case, when the renal pelvis is crossing the midline and reaching up to the iliac crest, or the child is presenting with a huge lump in abdomen. So how to decide whether we should go for pyeloplasty or an upfront ureterocalycostomy? If you look at literature, even in good hands, pyeloplasty may have a surgical failure rate of about 30%. And even after good pyeloplasty, he might end up in having a nephrectomy in 20 to 30% of the patients. If you look at the literature in Journal of Urology 1981, Levitt et al. Initially operated upon 18 patients in which primary ureterocalycostomy was done for PUJO. This study had a success rate of about 88%, but this was not without its failures. Like it was a retrospective analysis, and there were no properly laid criteria for selecting the patients for upfront ureterocalycostomy. Coming to the second study by Radford et al. From England in 2010, 13 patients were operated upon, and this study had a success rate of 92%. But same story as the last study, the study was a retrospective analysis, and there was no properly laid criteria. So the question still remains whether to do a pyeloplasty or go for upfront ureterocalycostomy. Why are we so much concerned about this? You can see that in a hugely dilated renal system, there is apoptosis and atrophy of the pacemakers, which are present at the minor calyces and the interstitial cells of Kale at the PUJ. This will lead to ineffective peristalsis and compromised results. But not only this, in addition to this, a sinking lower pole, which might reach up to the iliac crest at L4, L5, instead of the normal levels at L2, L3, will lead to ineffective drainage of the lower pole and compromise the results. So we at SGPGI had a retrospective audit from 2012 to 2015 in which 8 patients underwent upfront ureterocalycostomy, 6 by open and 2 by laparoscopic methods. This study had a success rate of about 90%, which was in tandem with the current literature in vogue. The success was a combination of multiple criteria based on resolution of symptoms as clinical criteria, resolution sonographic criteria, and nuclear imaging criteria. So in this retrospective audit, we found that certain parameters like the T-half, renogram curve, and the early drainage phase of the radionuclide were insignificant. Whereas on the other hand, the significant parameters were the late renographic phase, that is especially that after 6 hours. And in this retrospective audit, we found that the patients who underwent successful surgery met at least 2 out of the 4 criteria, like an aspect ratio, that is the width upon length of the kidney was less than or equal to 0.4. The ratio of maximum renal width upon maximum abdominal width was more than 0.5. The location of the dilated lower pole was mostly close to L4, L5 level, that is the iliac crest, or the cortical thickness was 4 mm or less. So based on this retrospective audit and this data, we proposed a hypothesis that why can't we go for an upfront ureterocalycostomy based on objective parameters if the patients meet 2 out of these 4 criteria. So these criteria are aspect ratio on NCCT is less than or equal to 0.4, in which we divide the maximum renal width upon the maximum renal length. The second criteria is the ratio of more than 0.5 of maximum renal width upon maximum abdominal width. The third criteria is the location of the lower pole up to L4, L5 level or beyond the iliac crest, or a cortical thickness of 4 mm or less. So if 2 or 4 out of these 4 criteria are met, we go for an upfront ureterocalycostomy. So keeping this in mind, we operated upon 17 patients, 70% by open method, 23% by laparoscopic method, and 1 by robotic method. Out of these 17 patients, 5 had a recurrent PUGO, which met the parameters. This study was over 3 to 4 years. And out of these 17 patients, 88% had a successful surgery over a median follow-up period of 22.4 months, which was also invoked with the world literature. So we conclude that in select cases, upfront ureterocalycostomy will give excellent clinical outcomes if selected properly in the intermediate run. The most dependent drainage is provided by upfront ureterocalycostomy in these hugely dilated systems as against a pyeloplasty. But the radiographic parameters which we included need further larger prospective studies to be validated. And my message that upfront ureterocalycostomy with good parameter selection will be the way to go in decision making in primary and recurrent uretropelvic junction obstruction. Thank you.
So thank you very much, Zain, for this crisp presentation. Stop sharing your screen. So we go ahead with the question and answer. Rahul, you will keep watch. So we first start with the Dr. Paul. Dr. Paul, you can go ahead with the first question without making your comment or observation. Dr. Paul, you are there?
Yeah, one question for you. You put in parameters, like 4 different parameters, and you had 2 out of 4. Does anyone have more significance than others? Because we know that failures occur if the parenchyma is thick. So if your parenchyma is thinner, then your anastomosis is much more successful. Does that carry more power than the other 3?
So out of the 17 patients, 15 were successful. In all of these 15 patients, more than 90% of the patients met the criteria of cortical thickness of 4 mm or less. So this criteria, according to us, played a more significant role in defining success as compared to the other 3.
So next, very quick question from Luis.
Thank you. Very good presentation. Just a quick question. So you mentioned one of the criteria to be parenchymal thickness less than 4 millimeters. But most patients that undergo pyeloplasty, they already have parenchymal thinning, which is less than 5 or 4 millimeters. So how does it make it different to use this criteria as a normal indication for UPJ obstruction to get a pyeloplasty? Because again, Dr. Merguer mentioned, I would expect you to say the parenchymal thinning of 2 millimeters or 1, because if it's very thin, then I think it's a good successful because there is less bleeding and then better outcome. But I would like to hear your thoughts on that.
Yes, sir. If only that criteria of parenchymal thickness has been met and the other 3 criteria are not met. So according to our study, it does not meet the criteria for taking up that patient for upfront ureterocalycostomy. Yes, we will not go for an upfront ureterocalycostomy if only 1 criteria is met. If the other 3 are also met, at least 1 out of the other 3, then yes, we will go ahead.
So you have to have at least 2 criteria.
2 out of the 4, sir.
Yes. So quick question, another question from Pramod. Pramod, go ahead, unmute yourself.
No, a great presentation. I like how you stratified your study design. The only concern I have is this, and also the other things is, do you have any concern that you are preserving very dysplastic kidneys that might have impact on the child's health later in life? Because we know that these dysplastic kidneys are higher risk for ongoing early onset hypertension and cardiac disease. So preserving this poorly functioning kidney, are you doing them any favors? Or are you putting them at risk for significant health issues later in life?
Sir, we'll be deciding upon the hypertension and the medical issues that the child will have in the eventual follow-up. In the cohort which we selected, the patients did not have any medical comorbidities to begin with. They were fit. But yes, eventually...
But by the time you figure it out, it's too late. The risk is preserving...
The benefit of doubt is always given to preserve the renal parenchyma so that as much GFR can be helped with for the child.
Luis, One more question from you.
Will, if it's possible.
Yeah, Malik, you can go ahead with the question. Go ahead.
What I was wondering is the standard of care in the primary PUJ, irrespective of the size of the kidney and the pelvis, would have been a pyeloplasty. Now that you are telling us upfront ureterocalycostomy with a certain parameters which are there, and if the child qualifies for it, an upfront ureterocalycostomy would be a better option. Can you give me a data about the pyeloplasty which you have done before versus a ureterocalycostomy, and what were their subsequent outcomes in terms of preservation of the kidney and the drainage? Or in any number of where you needed to redo those cases where you had these kinds of large kidneys?
Yes, sir. Out of these 17 cases in our prospective cohort, 5 had already undergone pyeloplasty. So that was a technical failure to begin with in their case. Plus, in other studies from our institute, the cohort of pyeloplasty had a failure rate of 30%, which was in vogue with the world literature. So we do not advocate pyeloplasty in such huge dilated systems if this criteria are met.
Okay, I have to check with Rahul. Rahul, is there any time?
Sir, we can go for one question. Actually,
yeah, Malik.
Early.
If you are not talking about a 30% failure rate, you have a 70% success rate for a upfront pyeloplasty. Do you submit all these children to a procedure which we are not sure about how far would be the long-term success rate versus a pyeloplasty?
Sir, we have not done a head-to-head study, a phase 3 trial for this, but the success rate in our study was around about 90%. So yes, it is definitely higher than pyeloplasty, but whether it is significant or statistically significant, it remains to be answered.
Yeah, sir. So what I would like to say is that in such patients, it is more important to have an effective drainage, and the dependent portion is very inferior and highly below. So for that, we would like to do a ureterocalycostomy to have an effective drainage, and we also believe that a pyeloplasty would not be really effective in such cases.
Okay, okay. So we come to the conclusion, a closure of this presentation. Running out of time. Thank you very much, team SGPGI. So before we move to the next presentation, we have a Professor Anand Kumar with us, our past president, immediate past president. Sir, unmute yourself, sir. But before you end your post of president, what your vision as a future for the pediatric urology? Or your future vision for pediatric urology?
Yeah, actually, when I joined Sanjay Gandhi, for some reason, there were a lot of slowly pediatric patients, they all started with ambiguous genitalia, and I did not have any knowledge about it. So I kept reading about it, started doing some operation. And then more and more patients started coming. Then all kinds of pediatric patients started coming, and suddenly there was a lot of load. Then I realized we have to develop a pediatric urologist. So we kept trying. We appointed one person, he went for training, never came back. We appointed another person, he went for training, never came back. Then third person was Dr. Ansari, who also went for training but came back and finally developed a wonderful department. And we are very thankful to him that he has developed world-class pediatric urology. So my dream, which was there, Ansari has fulfilled. Because I was doing a lot of pediatric urology, I was doing everything. And then I thought that is not good. But at least.
And couple of points, sir, you add what you are expecting from us in future. Very brief, sir.
Actually, most of the major teaching institution must dedicate 2 faculty members and their resources to develop a good pediatric urology department. And that is the way to go ahead. And otherwise, slowly and slowly, pediatric urology will go to the pediatric surgeons.
How USI can help, sir? Very brief. How USI can help in future?
The USI can help us in that, like let them have a subgroup in the USI. As a part of the USI, give them separate day for their pediatric presentation, pediatric discussion, and pediatric interaction. And they can also have a midterm pediatric urology meeting under the USI. And USI, it can help them if anybody wants to go for training with our known resources. We can send that guy for some more training and more exposure. And USI can also facilitate interaction of the different departments for the better exchange of ideas, research work, and they can also do multicentric trial and to develop the pediatric urology. So that USI can help us in doing all that.
Sir, thank you very much for sharing your vision, sir, for field of pediatric urology. Thank you very much. So we move to the third presentation, that is fourth presentation of today. That is again from SGPGI Lucknow. Dr. Puneet Kumar is going to speak on abdominal leak point pressure, a simple way to predict urinary incontinence following surgical treatment of unilateral ectopic ureter in girls. So big topic and mentored by none other than Professor Ansari. So you share your screen. Okay, your time starts now. Rahul, you keep watch. Go ahead, Puneet.
Good evening, respected teachers,
Yeah, your
seniors,
time
and
starts
friends.
now. Yeah, go ahead.
Good evening, respected teachers, seniors, and friends. I would like to thank USI Pediatric Subspecialty section and my mentor, Professor Ansari sir, for this opportunity in these difficult times to share our experience on an unusual scenario that has not been clearly reported in literature. That is how we can use abdominal leak point pressure to predict urinary incontinence following surgical treatment of unilateral ectopic ureter in girls. We have nothing to disclose. This presentation includes a brief note on the topic of our study in the initial slides, followed by our institution experience, and finally the conclusions. We know that conventional treatment for ectopic ureter are either reimplantation or in few cases it might be nephrouretectomy if it's a non-functional unit. But the story does not end there. The corrective procedures like ureteric reimplantation or nephrouretectomy alone in such cases may not solve the urologic symptoms. Because in some cases of unilateral ectopic ureter, concurrent malformation of the bladder neck or intrinsic sphincter deficiency may result in postoperative persistent urinary incontinence. So the corrective procedures alone in such cases may not solve the problems. So this postoperative persistent incontinence is seen even up to 80% after the corrective procedure for bilateral cases. So coming to the literature, urinary incontinence following the surgical treatment, we understand that all don't have the incontinence, but in current literature, the true incidence is not documented and this entity is not clearly addressed. Moreover, there is no preoperative test or parameter to suggest the post-op incontinence. So is there any objective criteria by which we can predict that which child is going to have persistent incontinence after successful correction of the ectopic ureter? To address this question, we have evaluated risk factors and role of abdominal leak point pressure to predict persistence of incontinence following the surgical treatment. So our hypothesis was that incontinent girls with unilateral ectopic ureter with a low preoperative ALPP will have postoperative persistent incontinence and may require additional procedures. So we know ALPP is the lowest value of the intentionally increased intravesical pressure that provokes urine leak. In the absence of a detrusor contraction, it can be either valsalva leak point pressure, which can be measured by asking the kid to inflate the balloon or to blow out against the closed fist, or it may be cough leak point pressure, which can be measured by asking the kid to emulate the cough. In our study, all the girls operated for this procedure between 2005 to 19 have been evaluated retrospectively. The parameters assessed in our history, preoperative imaging like intravenous urography, MR urography, C2 urography, widening cystourethrogram, and video urodynamics. We also recorded the intraoperative findings and persistent incontinence after the surgery. Here we shared two cases from our study. This is a case of left ectopic ureter managed with a left ureteric implantation, but the child had persistent leak in the form of stress urinary incontinence postoperatively. This is another case where the right ectopic ureter with non-functioning kidney underwent right nephrouretectomy. Again, the child continued to have persistent leak in the form of continuous urinary incontinence postoperatively. There were totally 25 young girls with a mean age of 10.8 years. These patients were divided into two groups. Group 1 who continued to have the incontinence at 3 months and group 2 completely dry at 3 months. So out of 25 girls, 10 were having persistent incontinence at 3 months and 15 patients were dry. So when you look at the characteristic of the patient, group 1 girls are little older, that is more of puberty and adolescent girls are seen in the incontinence group. When you look at the location of the ureteric orifice and the configuration of the bladder neck, the location, it was located distal to the bladder neck in 60%, and the bladder neck was open on cystogram in 90% of the cases in persistent incontinence group. Bladder capacity was comparable in both the groups, and these were not that statistically significant. The most striking finding was found in the urodynamic study, that was abdominal leak point pressure was substantially low in group 1 with a mean of 51.5 plus or minus 15 centimeter of water compared to 90 centimeter in group 2. It is observed that LPP of less than 60 centimeter of water recorded in 8 out of 10 patients, that is 80% in group 1, whereas compared to only 2 patients in group 2. It was statistically significant with a positive predictive value of 90%. Diffuser overactivity was also seen in 2 patients. So out of these 10 incontinence cases, 5 were managed with a bulking agent injected at the bladder neck, either by dextronumber, microspheres, or silicone elastomer. 3 cases were with very low LPP were taken for bladder neck reconstruction, and 2 cases are in the stage of pre-op evaluation and counseling. To state our limitation, this study deals with a specific group of population with a very specific and relatively rare entity. There is no current literature to compare these findings, hence it may be difficult to generalize these findings at this point. More prospective studies should be conducted in specialized centers to confirm these findings. So to conclude, more than 1/3 of the girls with unilateral ectopic ureter had varying degree of urinary incontinence when orifices are located at or distal to the bladder neck. It is more common if operated at a late adolescent than the younger child. So a low ALPP less than 60 centimeter of water may reliably predict the possibility of a post-operative persistent incontinence in these girls. So we recommend the pre-operative assessment of abdominal leak point pressure in these girls, which can be predict this distressing scenario. So this may further help in counseling the patient's parents for the probable need of secondary procedures for complete resolution of the urological symptoms. With this, I thank you all by saying that don't miss the opportunity to predict urinary incontinence by LPP as we missed it to predict and prepare for the second wave of COVID pandemic. Unfortunately, we missed it. Thank you.
Thank you very much, Puneet. To finish it in time, you stop sharing. Your question and answer time starts now. Rahul, you have to keep watch. So let us go first quickly with the Pramod, you first question.
Thank you very much. That was a wonderful presentation and a very important topic. Dr. Kumar, I congratulate you and Dr. Ansari on choosing that topic. As you said, it's there's not a lot of there. I guess, do you have any concerns about doing, because oftentimes we're operating on these children at a very young age. How reliable is your abdominal leak point pressure detection in a child who's that young, like less than a year old?
Yes, sir. In our tertiary center, we have received the patients which are mean age is around the group 1 is around 10 years and the group 2 is around different. So it is little bit on the early adolescent group. Actually, in the few data suggests that it can be either the infant or in the early childhood, but we are having in that group where we can easily predict these values and we can perform the study.
And is your abdominal leak point pressure correlating with the history that they're providing, where they are having that continuous incontinence?
Yes, sir. If it is like ALPP was less than 30, they used to have more of continuous, and if it is more than 30 or between the 30 to 60, it used to be the intermittent incontinence.
Okay, we have not bring the Chandra into the picture. Chandra, you can go ahead with a quick question, and thereafter Dr. Paul. Dr. Suresh, you mute yourself, sir.
Yeah, thank you, Dr. Puneet. The 2 patients who had bladder neck reconstruction, what is the follow-up in terms of bladder pressures and compliance in those girls?
Yes, sir. We followed them with after the bladder neck reconstruction at 6 months with an MCU and CMG. There is an increase in the ALPP, sir. It was usually less than 30, which had been operated for them. It has become more than 60 in those 2 patients, and they're fairly confident to provide themselves.
Did you do a concomitant Mitrofanov or any such procedure?
For those bladder tourniquet, no, sir, we have not done for them. Not done, sir. If it fails, then it is the next step we may think of like redoing the procedure or bladder neck closure or Mitronov, sir, at the later stage.
Okay, Dr. Paul.
This is a follow-up on Dr. Reddy's question. So a lot of these patients are diagnosed either antenatally or diagnosed right after birth. And how do you think predictable is the abdominal leak point pressure if you do it in a 3-month-old or a 6-month-old or a 1-year-old versus your group, which was older group?
Dr. Ansari would like to take this question. Unmute unmute yourself, sir. Unmute.
I agree with Dr. Paul and Dr. Pramod Reddy for very pertinent question, because before a child of 3 years or toilet trained, ALPP does not carry much meaning. So, and this was just an incidence that because of the late presentation, we had a median age of 6 or 7 years. So in that way, we can very well elicit LPP as well as it is quite reliable. Under 3-4 years, it is really not only difficult, but the reliability is also very less.
So Pramod, you want to put additional question on this?
No, I agree completely with Dr. Ansari, and I think it's just a difference in presentation, right? So seems like the cohort of patients that you saw were older.
Pramod, do you have a more question?
Yes.
No, I think they did a good job. And
okay. Malik, you go ahead with your question.
Puneet, I was just wondering, how do we actually look at the abdominal leak point pressure in a girl child who is constantly leaking, where we would not probably have a good bladder? Forget about the age. Now we look at the same age group as 6 or 7 years or 8 years. If there is a leak, intermittent leak, yeah, fine, fair enough. But if the child is leaking constantly, how would you evaluate the abdominal leak point pressure?
Yes, sir. In that scenario where there are few studies in this one also, when we have done the MCU also, the mean bladder capacity is around 230 ml in group 1 and group 2. There was fairly bladder capacity is enough, fair enough. But yeah, if it is continuously leaking, we may get a error in the value. That we have to keep it in the mind.
But if these children follow it up, whoever had
done.
Okay. So Malik, you want to finish the question?
Yeah, it's a question. Yeah.
Okay, fine. So we've come to the closure of this presentation. Thank you very much, Dr. Puneet. Before the judge puts mark, I want to bring the Luis. Luis, we can have some discussion with you. Luis, you unmute yourself. Dr. Braga, are you there? Okay, he is having some problem. So go with this question to Dr. Paul. Dr. Paul, you unmute yourself, sir. How frequently, sir, you get a poorly functioning kidney with UPGO obstruction? How frequently in USA? Maybe because of it is developed country and more aware, probably. I don't know whether that makes any difference. And what is your long-term experience when we go ahead with the either pyeloplasty or some other kind of reconstruction? Medicine.
I think the incidence of poorly functioning kidneys is not very high. So as you saw, even the numbers in India are not that big; they're small. I've tended to reconstruct those, and I think there's evidence to support that there may be increase in function. The question I have regarding that is, DTPA renal scan may not be a good, and I wonder if there's actual increase in renal function, or is it because the parenchyma is less decompressed, so you actually have better prediction of differential renal function rather than a true increase in renal function with these kidneys. And I think it's important to determine that because personally I feel that renal function may not improve even after a pyeloplasty, but there are several studies that have shown that there is increase in renal function. That the question is, are the tests that we're actually using to predict renal function accurate enough?
Thank you, sir. Luis, quickly. So unmute yourself. So the question is that how frequently you see this kind of cases? Can you hear me? And another thing is that how exactly you judge the improvement and how exactly you communicate with your parents, means patient's parents. Reason is that suppose they say that, sir, nothing much improvement is seen in your post-operative investigations. How exactly? So you have 2 minutes to share these issues.
Sorry, for me, right?
Yeah. The thing is that how frequently you get this kind of cases of poorly functioning kidney with UPGO, and secondly, how exactly you judge the improvement and how
Yes.
you communicate with the parents?
Yes. So again, those cases like have Paul and then everybody else had mentioned, they are rare cases. So I think the main thing that is that for those cases, I think there is a recent paper from I think Rom and Asim Shukla from Philadelphia showing that patients that had those poor functioning kidneys did well post pyeloplasty. So I think what I want to comment here is that Pramod already mentioned that he's concerned a bit about having a dilated kidney. So I have changed my philosophy in terms of preserving kidneys that are poorly functioning or in terms of the risk of future hypertension, proteinuria, and infections. As long as the kidney is not obstructed and the patient doesn't have VUR, in my experience, and from others, is that those kidneys, they do fine. Again, the follow-up is not long enough, but that's the same concept that I have used to treat patients with upper pole dilatations. I don't do renal scans because I'm going to do a UU regardless of the function of the upper pole. And I have adopted the same thing for an obstructed kidney with UPJ obstruction. You can do the pyeloplasty, you disobstructed, that kidney will stay there. To make a quick comment about pulse point, it's very valid. I think the fact that the function is improving, I think may not be necessarily a reflection of true improvement. I think it's hard to really rely on a renal scan in those poor function kidneys, even though a lot of the times we do MAG3s, but maybe at DMSA, I have done both tests. And sometimes when you order DMSA, you can have a bit of better function. So the other point is the age. I think if you do those cases under 3 months of age or under 6 months, we have seen in our data, we only have 11 patients that the function has improved. In other patients, it hasn't done anything. So, and then final question, there's from training, I learned that in those huge, massive hydronephrotic kidneys, the classic teaching was to put a nephrostomy tube to then decompress the kidney, repeat a scan, and then operate. I think it's not necessary. You don't gain anything unless the patient is very sick and septic, but it doesn't happen often. So when you go back, you have attachments, adhesions, the pyeloplasty is more difficult. So just go ahead, do the pyeloplasty, and then if the kidney drains well, you can have a successful thing. Okay, so you explain all that to the parents, and then it is what it is after.
From both Dr. Paul and Dr. Luis, thank you very much. We'll go on this issue with to Dr. Professor. Yeah, Pramod, quick comment.
Real quick question for Luis and Paul. How aggressive are you with your reduction pyeloplasty in these massively hydronephrotic
We'll give you time. We'll give you the slot. Let me finish the next presentation because we'll definitely keep this thing. And we will bring Professor Venugopal, the experience also this. So we are not finished with this discussion. We move to the next presentation. That is the fifth presentation of the day, and that is from Bikaner. A very interesting topic of male Epispadias repair. Their experience they are sharing. Dr. Ajay Gandhi is presenting and mentored by the Dr. Yogendra. They are from the Sardar Patel Medical College, Bikaner. So, Dr. Ajay, you share your screen.
Yes. Good evening.
Share your screen, Ajay.
Yes, sir. I have shared.
No, there is some issue. You sort out the issue. You sort out the issue. We can move that by that time. Are you sure that you are in position to make it quickly? Okay, fine.
Yes,
fine. Go ahead. Make it full screen. Make it full screen. Okay. Your time starts now.
Good evening, all respected seniors and judges. I am presenting our experience on male Epispadias repair. We have no conflict of interest. The aim of Epispadias repair is creation of cosmetically and functionally acceptable penis and management of incontinence and vesico-ureteral reflux. It is very rare anomaly. Incontinence occurs in 70% of pinopubic Epispadias cases. In the last 6 years, we have managed 23 such cases, out of which 17 were male and 6 were females. Among the males, 14 were pinopubic and 2 were penile and 1 was granular Epispadias. This is the pictorial demonstration of the different steps of Epispadias repair. These are the different steps which we will see in the upcoming video. Here we are presenting a 15-year male with glandular epispadias. These are the problems associated with epispadias. Demonstration of the dorsal chordee. All the operations were done with the modified Cantwell-Rensley technique. IPGM suturing done to direct the stream forward. Penile degloving done. Dissection of urethral plate from the left corpus. Followed by right. All the three corpora were separated. Granular incision marked and infiltrated with local 1:1 lakh adrenaline. Granular incision given. Granuloplasty done in 2 layers. This is the second layer, subcuticular closure of the glands. Rensley incision given on both corporas to prevent injury to the neurovascular bundle and avoid glans necrosis. And finally, both the corporas are medially approximated. This is the completed closure with drain. Postoperative photograph at 4 weeks and the video of the wording of the same patient. We had 4 complications in our patient. 2 were ureterocalycostomy fistula, 1 was wound infection, and none of our patients developed glans necrosis or stricture urethra. 6 patients were continent, out of which 5 were acceptably continent and 1 had incontinence. This is an excellent video of the continence by young dysrepair. Here the results of our study were comparable with the other studies, and in our study 2 patients developed ureterocutaneous fistula and 1 developed urethral wound infection. 5 patients underwent bladder neck repair and ureteric reimplantation. This is the article which we have published recently. Now take home message. It's a rare anomaly, requires skillful and meticulous surgery, preservation of neurovascular bundle and correction of chordee, aesthetically acceptable penis, and correction of reflux and incontinence are paramount. Thank you, USI, for giving me this opportunity, and thank you all for the patient listening.
Ajay, for this precisely completed presentation. So unshare your, stop sharing the screen. We can move to the question and answer. I can see the faculties. we please
Sir, we have
stop sharing.
30 seconds extra also in this.
And the thing is that we have decided here first question from the Pramod, followed by the Dr. Paul, and then one from the Professor Hemant Pathak. So, Pramod, quickly your question.
Sure, Dr. Gandhi, excellent presentation. Thank you very much. Great results. Enjoyed the video.
Thank you, sir.
Question is, I think that your conclusion that the ultimate goal is not just continence, it is cosmetic appearance, it is sexual function. Some of your patients are older. Are you seeing what their erections are like? Are you following them along, and are you checking the psychosocial impact on these patients? Because as you know, the quality of their perception of their genitalia is important. So I know that's the psychological impact is important. Are you following the psychological trends of these patients at all? Especially the males. Not to be sexist, but.
Sir, in our study, most patients were of the pediatric age group. Only 2 patients were adult. And these are in the pediatric age group. The 2 adults have good erections.
Okay. You happy, Pramod? Do you want to add question? Otherwise, I go to the doctor.
No, and then the other question is, are you assessing, with your continence, because you have these children a little bit older, are you assessing their preoperative bladder capacity and urodynamics to help you understand what's going to happen after you add the additional resistance of the urethra and the bladder neck? Are you doing preoperative urodynamics to help correlate your postoperative bladder outcomes?
Right, sir. Yes, sir.
And what are you seeing? What are you seeing? Are these bladders mostly okay? I mean, especially with the glandular Epispadias, you probably will have normal bladders, but what about the more proximal Epispadias? What are your urodynamic studies showing?
Your teacher, your mentor can intervene directly.
Yes, sir.
Sir, in most of the cases, the bladder dynamics were normal. We didn't find any problem on urodynamics.
Perfect. So if your bladder dynamics are normal preoperatively, then you're going to get great results postoperatively. So that's fantastic.
Dr. Paul.
Thank you.
Yeah, quite a great presentation. A question for you regarding the corporal bodies, and a lot of us are doing external rotations versus internal rotations of the corpora. One question. The second question, do you really need to incise the corpora in order to approximate them? Could you just suture them and rotate? If you could comment on these two.
Routinely, we are doing the internal rotation to correct chordee. And if we don't incise it, the sutures give away, and we feel that such patients will develop eventually chordee maybe after a few years.
But it's really to follow these patients long term.
Yeah, they need follow up until they have attained age for the marriage and sexuality.
Because it could be that the internal rotation will not solve the problem, and you may need to externally rotate. Most people today are externally rotating corpora instead of internally to repair the curve.
Sir, most of our patients have been children, and they have not attained that age, so we are not able to evaluate. But we have done 2 adults. They are happy with the results. Both of them are married and sexually cohabitating.
Yeah, Dr. Ajay, you had a sizable number of pinopubic Epispadias, 11. Out of them, how many were incontinent at presentation?
Sir, out of these, we have 7 patients who initially had extrophy.
Okay. So it's a different.
So different age groups we are having. So we have done 6 patients. We have done bladder neck reconstruction. Out of these, 5 have good continence.
Okay. Now I'm coming to only 1 minute.
Pardon?
Out of those only pinopubic Epispadias, out of the 4 which you have had, you have done primary bladder neck reconstruction along with Epispadias repair, or you have staged the.
Sir, we have staged it.
Any reason? Same as Dr. Pramod was asking. You expected that they would become dry by only urethral resistance?
No, we do Epispadias repair earlier, say around the age of 6 months to 1 year, and with increase in urethral resistance, we expect some increase in the bladder capacity. So then it is better to do bladder neck reconstruction. At least they have 60-70 ml of the capacity.
Rahul, do we have a time? Okay, fine. So this is a closure of this
very important point.
Thank you very much. So I'm coming to you, Pramod, very quickly. Now,
one very important
forgive
point
me
is that
forgive me for the format is like that, and I just now saw the comment of Luis that it is a very interesting format. He is enjoying this contest. He's appreciating the quality presentations, and he is expecting much more time to interact. I will request Professor Kesamurthy that when we organize a global event, I'm sure that all of you are going to participate, and that time many other countries are also willing to participate. And I will request Professor Kesamurthy to give me a format of 2 days, so we can have a little more time, equal time of a presentation and the discussion. It's okay, fine. So we'll raise that issue to Dr. Professor Kesamurthy later on. Here, believe me, I have to follow the format. So let us see discussion first. Pramod, you wanted to discuss with the Paul and the Luis. Just first that, and then you make a point for this presentation.
Well, I just wanted to make one important point, which is I think that.
But your comment will not influence the judges' decision.
No. This is just a general statement that, again, I just wanted to, reinforce what Dr. Gandhi is showing is that I think anytime we're looking at children with bladder exstrophy epispadias complex or isolated epispadias, yes, they are part of the spectrum, the same spectrum, but is very different if you have a normal bladder at the beginning. So when you're lumping the patients with bladder exstrophy epispadias and comparing those outcomes with patients with isolated epispadias, it's a very different. Now, penopubic epispadias, yes, I agree that they are a manifestation of a minor variant of bladder exstrophy, but glandular epispadias, I think they should be considered a totally separate entity and the results will be very different. I just wanted to make that important distinction there.
Okay. Second thing is that you wanted to raise a question, Paul and the Luis, quickly, and then I will sum up on with the Professor Venugopal's comment on that. Yeah,
sure. So
the question you was raising, yeah.
So Dr. McGurrian and Dr. Braga, and I know Paul, Paul's one of my teachers, and we travel to India every year. So I know that Paul is doing the external rotation like I do. Louis, what are you doing with your chordee correction for these epispadias and bladder exstrophy patients? Dr. Braga? You lost him?
Okay. Okay.
Then Paul, do you
Pramod, you wanted to ask question on poorly functioning, I think poorly functioning kidney. Yeah.
Oh no. The question from earlier on is that I was just asking both of them, how aggressive a reduction pyeloplasty do you do in these very poorly functioning, massively dilated kidneys? And is there any benefit to doing that to improve the capacity and drainage of those kidneys, or do you just say it doesn't matter, just leave them alone?
In addition to that, I want to know any role of plication, getting the kidney to reduce the dilated volume. Let's promote.
I've not been too aggressive in reducing the pelvis.
Okay. I don't know. I feel like if you don't reduce the pelvis, are you changing the dynamics across that UPJ at all by having a larger volume? So Louis, the question we're talking about is how aggressive do you have to be with these massively dilated, poorly functioning kidneys in terms of a reduction pyeloplasty? Is there a benefit? Is it not? Is it just to make the kidney look prettier on postoperative images, or is there actually a dynamic benefit from the mechanical elastic properties of that pelvis?
Yes, sorry, I had to answer a page like from a call, but again,
quick answer.
Yes, a quick answer. Yeah. So I always, not only for those cases, but I tend to reduce the pelvis in most pyeloplasties or all pyeloplasties I do. So that's how I learn. I think it's important because once you reduce the pelvis, you're able to get and also spatulate well the ureter. You get a very dependent anastomosis. So I think that's the key. If you can get a dependent anastomosis with a redundant pelvis, it's fine, but sometimes you cannot. and that's why when you end up with problems and stasis and that prolonged curve. So Pramod said that he's right. If you resect more the pelvis, you have a better visual aspect of ultrasound and stuff like that. But again, I do believe that having the dependent anastomosis is a huge factor to allow you for post-op, especially because in poor functioning kidneys, the Cajal cells will not contract well. So this one is one more reason to have it resected.
Quick comment from the Dr. Paul.
So, Luis, there's no evidence for that. I don't think you can compare it to anything else. If you look at the people doing these, they tend not to reduce the pelvis. They have exactly the same results as open pyeloplasty. So
absolutely agree. Absolutely agree.
I have to disagree with that. You also don't have any.
Okay, we'll keep that debate pending. We go to the Professor Venugopal to share his experience working on pyeloplasty or ureterocalycostomy in the very poorly functioning dilated kidneys.
Can you hear me?
Yes, sir.
I think I should go back about 55 years back as far as to give an answer for this. During the early days, we did not have ultrasound, we did not have DTPA scan or any scan of anything. We didn't have CT scan. We all went only by IVU. And that is something that you should remember, that when we have a case with a poorly functioning, a delayed IVU picture will give you some information as to whether this kidney has got some function or not. And that was crucial at that time in our practice. Now, coming back to doing surgery, when you have a huge poorly functioning kidney on IVU with delayed appearance of contrast, or sometimes no appearance of contrast even, a large calcium system, and such cases, we had a lot of difficulty in deciding what to do. Should we do an nephrostomy, or should we not do a nephrostomy? Or should we do a primary pyeloplasty, or knock out the kidney in this poorly functioning kidneys? These are the only issues that came to our mind in those days. I'm not talking about today. Remember, all this came, whatever you are talking about, ultrasound, isotope study, etc., came in much, much later in our practice. What is important for us was, should you do nephrostomy or not? My policy was that if the kidney was infected, even if it's a solitary kidney, or if it's a unilateral hydronephrosis, if it's an infected kidney, I would do a nephrostomy. And that I mind you, there's no PCN, it is only open nephrostomy. Remember, those are all difficult times that we had. But what is more important is, once you've decided to do a pyeloplasty, or you are going to do a procedure for the patient, what should be done? How effective the treatment should be. Now, once you open up, my first thing was, look at the renal parenchyma, how thinned out it was. If it's almost transparent and the fluid is looking blue in color, through the parenchyma, then you know that the parenchyma is absolutely thin. The next point that I look for is, look at the renal artery pulsation. If the renal artery pulsation is good, that kidney has a chance of recovery. If the renal artery pulsation is poor, that kidney does not have a chance of recovery. These are two things on the table that I used to do. If I am doing a nephrostomy, I used to do urine parameters, and that's only available investigation at that time. And if that shows some saturation, there is no alkalinization, there is no osmolality change, much of changes, and also the output is good of nephrostomy, I would take this child for pyeloplasty.
Thank you, sir. Thank you for sharing.
Pyeloplasty is a very important thing, that to decide which cases to take for pyeloplasty was important by our crude method of evaluation of those days. I think I answered.
Thank you very much for sharing, sir, your vast experience. Very excellent points. That is very much relevant in era, and still I think it is equally relevant. A very quick comment from Amilal Bhatt. He's raising the finger. Thank you very much, Professor Venugopal, sir. Unmute yourself, Dr. Bhatt.
I would like to make two comments. one on the Epispadias. You see, in Epispadias, it is required to correct the chordee as well as torsion, even in the penile or the even glandular. You will have to mobilize the whole urethra to bring the urethra down. And when you mobilize it, then you get the full mobilization and you correct the torsion as well as the chordee. Number 1 point. Number 2, as Pramod has raised the point of incontinence. If it is a penopubic, more than 50% of them are the incontinent one. I go with the reconstruction of the, you go up to mobilization of the urethra ventrally up to the membranous and proximally up to the bladder neck. Do the double breasting of the posterior urethra and you get the continence. These are the 2 important points which I wanted to make.
Sir, we have a plan to have some more discussion on Epispadias.
Okay.
To raise the 2 points, we will take a couple of comments from the Pramod. Comments little later. Yeah. So
I would like to make 1 point more on a pyeloplasty also later on.
Okay, fine. But you make a point on the pyeloplasty because we are closing that discussion.
Pyeloplasty, you see, as Professor Venugopal has raised, there are 2 questions. One is that if it is a poorly functioning, hugely dilated, now there are 2 things. You see, many times you put in the nephrostomy and after 4 to 6 weeks have the renogram again. The renal function improves. This is one of the guidelines to go for the pyeloplasty.
Perfect.
And similarly, few people even put DJ stent and control the infection. And if this renal function improves, this is an indication for pyeloplasty.
I have some doubt. My reservation for DJ stent will, if we get a time, will come for that point. But for your first point well taken. So we move to the next presentation. We'll be sparing some time for the Epispadias discussion. So we are moving to the next presentation. That is 6th presentation from Dr. Mahakshit. He's from the NIMS Jaipur. He's going to speak on a systemic approach to chordee correction, mentored by none of other Dr. Amilal Bhatt, his father. Yeah, go ahead. Your time starts now, Mahakshit.
Recording.
Mahakshit, you okay? Oh, no audio from you. Yeah, okay.
It's fine now, sir?
Yeah, share your screen. Yeah, okay. Okay, now go ahead. Your time starts now.
Yes, sir. Good morning to the international faculty and good evening, everyone. I'm grateful to the USI to give me an opportunity to present systematic approach to chordee correction. Now, why do we need to correct chordee? As a significant curvature of more than 30 degrees will impact sexual function in the future. The causes of chordee might lie in any of the one or more of the ventral tissues of the penis. And the evaluation of chordee traditionally is done by the Gitti's test, which is intraoperative, and we can use a goniometer to assess the exact degree of chordee. With the use of elastography, we can preoperatively determine the stiffness of the tissues, and in the future, it may become a staple for investigation of chordee. Now, common methods of chordee correction are penile degloving with or without dorsal plication and transection of the urethral plate. However, the commonest complaint of hypospadias in adulthood is a short penis, and dorsal plication contributes to shortening of the penis. So we devised an algorithm which predominantly approaches the causative tissues, that is the ventral tissues of the penis. And the steps for chordee correction are as follows. The first step is penile degloving, which corrects the skin and dartrose contributions to chordee. And we can see in the pictures on the left is a case of mid-penile hypospadias, where the chordee is corrected by degloving itself. And on the right is a case of chordee without hypospadias, where chordee was corrected with penile degloving. The next step is mobilization of urethral plate and spongiosum, which corrects the spongiosal contribution of chordee. On the left, we can see a mid-penile hypospadias, where the chordee was corrected by mobilization of the urethral plate and spongiosum. And on the right is a case of chordee without hypospadias, where chordee was corrected by mobilization. Now, if still the chordee is not corrected, then we can mobilize the spongiosum into the glans, which corrects the glandular part of the spongiosal shortening. And in the photograph, we can see achievement of correction of curvature in this case. And on the right, there is a case of chordee without hypospadias, where curvature was corrected after mobilization into the glans. Now, if the urethral plate is still short, then we can mobilize the urethra proximally Normally, in cases of distal hypospadias, we mobilize it up to the penoscrotal junction to add length to the urethra. And in severe hypospadias, we can mobilize it up to the bulb. And we can see in the photograph clearly the chordee correction has been achieved with adequate length of the urethral plate and spongiosum. If still not correcting, the next steps are resection of tethering tissue and midline dissection, which corrects the buccal fascial contribution to the chordee. In the photograph, we can see the urethral plate and spongiosum have been mobilized and midline tissue has been dissected to achieve chordee correction. The next step is lateral dissection of the buccal fascia if correction is not achieved by midline dissection. And in this case, we can see the lateral reflection of the buccal fascia has corrected the chordee. So this can be followed by either of the two, the ventral lengthening or a dorsal shortening approach. We prefer the ventral lengthening approach. However, if needed, we can go for a dorsal plication. And after all the steps, we can see that the length of plication required is minimum, and we can achieve greater postoperative penile length when we do dorsal plication as a last resort rather than the first step. Glansplasty and spongioplasty themselves help in regaining the length, that is Y to I spongioplasty, and the glansplasty corrects the glandular chordee. Now, similar steps can be achieved where the urethral plate is very short, and in these cases, we transect the urethral plate at the corona, preserving the maximum amount of urethral plate. We can see in the pictograph here, the urethral plate is short, so we have transected it at the corona and achieved chordee correction by midline dissection in this case, and lateral dissection of buccal fascia in this case. The preserved urethral plate can be used to reconstruct the neo urethra, and the spongiosum preserved can be used to cover the anastomosis of the urethral plate and the inner preputial flap tube used to prevent fistula formation. So coming to results, in anterior hypospadias in the case study in 2007, we needed to transect the urethral plate in 2 cases, and dorsal plication was needed in 2 cases. However, in the recent data, which we have not published, in distal and middle hypospadias, we have required dorsal plication in only 2 cases, and there is no need of transection of urethral plate. Similarly, in proximal hypospadias, we can see that a large number of patients can be corrected by penile degloving and transection of the urethral plate, and the need of dorsal plication was needed only in 6% in 2007, and in recent data, only 3% cases. So the rationale is that the chordee may be due to a single factor or a combination of factors, and the step-by-step approach is based on anatomical and surgical principles. Each step corrects a contributing factor to chordee, that is penile degloving corrects the skin and dartos components, mobilization of spongiosum corrects the spongiosum component, midline dissection and lateral dissection of the buccal fascia corrects the buccal fascia component, spongioplasty and glansplasty correct the spongiosum. And if still not corrected, then we can go for a dorsal plication or superficial corporotony and corporoplasty, which correct the dorsoventral corporeal disproportion. So the take-home message is that the step-by-step method in chordee correction deals with all etiological factors. Then we have to confirm correction of chordee before urethroplasty to reduce recurrent chordee. And this step-by-step approach, along with preference for ventral lengthening procedures, reduces the chance of shortening of penis. It increases chance of urethral plate preservation, urethroplasty, and spongioplasty and glansplasty construct a near normal urethra.
Thank you, Makshit. You can stop sharing the screen. Dr. Braga, you be prepared with your question. Unmute yourself. Go ahead with the 2 questions.
Thank you very much. It is a very objective way of correcting hypospadia. So my question is that I totally agree with the points. Each steps, but in my hands, I do 2 things in a different order. So why do you try to mobilize the urethral plate and lift the urethral plate before you excise the lateral chordee bands and then even the buccal fascia? So that's question number 1. Can I have a second question? Yes. At the end, you conclude that you're doing this preserving the urethral plate. So this, unfortunately, has been in contradiction to my experience. I think as I got more experience, I have been transecting the plate much more than before. So I still think that a shorter urethral plate has a role in those more severe cases of hypospadias with severe curvature. I would like to hear your comments.
Yes, sir. Regarding the first question, sir, we proceed from superficial to the deep components of chordee correction. So if the cause of the chordee lies within the skin and the dartos, or even the buccal fascia, it will get corrected by each step. So if the chordee is corrected by mobilization of urethra itself, then we do not need to proceed to further dissection and increase the chance of further complications. And regarding the second question, sir. Yes, sir.
Because sometimes it is very nice as a didactic way, the way you put it, and I totally agree. I congratulate you on that. But sometimes chordee is a multifactorial issue. You have more than one problem.
Louis' question.
Yeah, the problem that's the question, that it's only, you cannot correct one thing for one chordee just due to spongiosum. There are several factors that are responsible for chordee, so you have to approach all of them.
Yes, sir. That is what we're trying to say, sir. So we do not do a ureteroplasty or a summation of the procedure until we confirm by a Gitti's test and a goniometer that the chordee has been corrected. Yes.
Next question from Dr. Pathak.
Thank you, sir.
Yeah, Dr. Mahashe.
Yes, sir.
You have concluded that you don't have to transect the urethral plate. I'm just repeating what Dr. Braga also raised a concern. That is there any role for any ventral approach for correction of chordee? Because your message was that shortening of the penis is because and chordee correction. So my question is, means you would avoid transecting the urethral plate, and is there any role for ventral correction? I mean, by incising the tunica, putting a graft.
Yes, sir. So regarding the first part of the question, sir, if after mobilization of the urethral plate and spongiosum, we see that the urethra is significantly short and will not be able to achieve chordee correction, we transect the urethral plate as the second step itself. And then we go for ventral lengthening approaches because we prefer ventral lengthening approaches because then again, short penis is not a problem in the future. And if still not achieved, then the last step we go for is a dorsal plication or a dorsal shortening approach.
Question from Chandra. Yeah, Chandra, go ahead.
Yeah, so thank you. So the whole comment on that.
Sorry, sir?
The impact of urethral mobilization on ischemia and resultant increase in urethral strictures in overgenerous zealous proximal mobilization to avoid dividing the urethra. What is your opinion on that, please?
The opinion, our approach is that we approach the mobilization of urethra in the correct plane, that is at the level of tunica albuginea, so as to avoid damage to the spongiosum itself. And we mobilize the urethra only as far as the extent where curvature is corrected. So in distal hypospadias, we usually mobilize it up to the penoscrotal junction or just below it. And in proximal hypospadias, where more mobilization is needed, we go only up to the bulb and not more proximal so as to avoid vascular damage.
Rahul, do we have time, Rahul? Dr. Hemant, Dr. Pathak, you can ask last question here.
So just to ask, in cases of severe chordee, in how many cases would you stage the hypospadias, or always you try and do it in a single stage?
Again, when in our algorithm, we approach the stage procedure as once we've achieved a complete chordee correction. And if an inner preputial flap tube is available and the length of the inner preputial flap tube and the proximally mobilized urethral segment is adequate, then we go for a single stage procedure. And if these lengths are not adequate, then we prefer to go for a stage procedure.
Okay, thank you, Markshit. That is closure of your presentation. Thank you very much. As I have an instruction from the secretary, sir, I request judges to put the mark. Before that, I start announcing at the same time with the next presentation, that is from the Dr. Arpit Sharma. He is from Mahatma Gandhi Medical College, Aurangabad. He is going to speak on pediatric mini-PERC and thulium fiber laser lithotripsy. He's mentored by the Dr. Abhay Mahajan. So, Arpit, share your screen.
Am I audible?
Yeah, audible. Your time starts now. Rahul, you keep a watch.
Good evening, respected judges. The topic of my presentation today is pediatric mini-PERC and thulium fiber laser lithotripsy. I'm being mentored by Professor Abhay Mahajan. Conventional PCNL is a standard procedure for renal stones in pediatric population but it has the following drawbacks like pain and bleeding. To decrease the morbidity, but to achieve an equal stone-free rate, especially in pediatric patients, a miniaturized version of PCNL, that is mini-PCNL, was introduced in 2001. The term mini-PUC refers to a tract size between 14 French to 20 French. According to the European Association of Urology, following stones can be subjected to mini-PUC: the lower pole stones of 1 to 2 centimeters, calycial stones 1 to 2 centimeters, and renal pelvic single stones less than 3 centimeters. In the last 3 years, we have operated upon 32 patients with renal stones in the pediatric population, aged 1 to 16 years at our institute. A proper patient history and physical examination is done, and the patient undergoes urine analysis, urine culture, renal function tests, CBC, and coagulation tests. USG, abdopelvis, and X-ray KUB are done. A low-dose NCCT KUB or a CCT KUB is done, and renal scan is done only in poorly functioning kidneys. All the patients are given general anesthesia. Usually, we put 3 or 4 French ureteric catheter under C-arm guidance. The procedure is performed in prone position. Appropriate calyx is selected for puncture. These are the various scope and accessories available. Out of this, we use the MIP-M with a 16.5 and 17.5 French outer diameter and a 12 French nephroscope with a 6.7 and 5 French working channel. The procedure is, after putting in the glide wire initial, dilatation is done with a screw dilator of 12 French. Subsequently, single-step dilatation with a metal dilator of 16 French is done, over which the metal sheath is introduced. The stone is fragmented from periphery to center using a thulium fiber laser with energy settings of 1 joule and 10 hertz. And if the stone is harder, we raise the energy to 15 watts. And created smaller fragments are done so that the drainage is better. While comparing lithotripsy parameters for holmium and thulium, we see that ablation rate, fragmentation, and dusting are 2.5 to 3 times higher for thulium. And the laser time and operative time for holmium is 2.5 to 4 times higher. This graph depicts that the stone retropulsion is higher in holmium. For equal laser parameters, thulium fiber laser has a higher ablation rate, as shown here. The stone removal is done using the vacuum cleaner effect. Continuous irrigation during withdrawal of sheath develops a vortex in the lumen of the sheath, which produces a vacuum cleaner effect that helps to expel the stone fragments. We generally prefer to keep a stent to facilitate the drainage of fragments and to avoid colics because of the fragments. We usually prefer to do a tubeless procedure, exceptions to it being infected system and bleeding. Patients are advised to come for DJ stent removal after 2 weeks. Removal of stent is preceded by USG and X-ray KUB to assess the stone-free status. Further follow-up is done with 3-monthly sonography till 1 year. This is the result in which we achieved a stone-free rate of 96.87%. The need for analgesics in the first 24 hours was less, and the drop in hemoglobin was not significant with a p-value of 0.189. When we compared other studies, our study with other studies, the stone-free rate was quite comparable. A comparison of various treatment modalities for lower calycial calculi found mini-PUC to be the first-line procedure due to a better stone-free rate and low auxiliary and retreatment rates. As far as safety and efficacy of PCNL in the pediatric population is concerned, it was recommended that the tract dilation be restricted to 24 French or smaller. In a large study of 639 patients, it was found that pediatric PCNL was associated with low morbidity, high success rate, and a shorter hospital stay. When it comes to complex calycial calculi in children less than 5 years of age, mini-PUC helped in achieving maximum stone clearance with minimal morbidity. In a comparative study of PCNL in pediatric population, it was found that increasing the tract size was associated with a higher incidence of hematuria and renal extravasation. So to conclude, a reduction in the tract size definitely helps in reduced bleeding and drop in hemoglobin. The stone-free rates are almost the same in PCNL and in mini-PUC, but PCNL causes significantly more pain. Therefore, we suggest that whenever possible, all pediatric kidney stone requiring percutaneous endoscopic removal should be performed by mini-PUC, and that thulium fiber laser is a better modality for lithotripsy. Thank you.
Thank you very much, Arpit, to finish it in time. Your question answer time starts now. Rahul, you have to keep a watch. The first question from Dr. Paul, followed by the Dr. Anand Kumar, and if time permits, we'll ask Pankaj to ask the question. So, Dr. Paul, you have
almost 5 minutes.
This This is a great presentation, and I commend you for this. My question for you, in pediatric population, it's important to reduce radiation. So the question is, have you tried the mini-PERCs with ultrasound guidance, and do you do them supine or prone? Because supine position has been also associated with a better outcome or easier outcome, because you can cystoscope them at the same time.
Yes, sir. Thank you for the question. So regarding the first part, we usually do it C-arm guided. In our institute, we don't have that ultrasound guided access approach. We are comfortable doing it under C-arm guidance. And we have been doing all the mini-PERCs in the prone position, not supine. We are very comfortable with
the question is not comfort, but do you think that to reduce the radiation, how much the radiation you calculate? Do you calculate the radiation to the child?
No, sir, we don't. No, sir, we don't calculate it, but we definitely can do it USG guided. We can definitely get the access USG guided, but in our institute, we don't normally.
Next question is from Dr. Anand Kumar.
Yeah, my question is, when you do the stone-free rate, you do the ultrasound and KUB. Both are not a very reliable. They have around 50-60% accuracy. For the study purpose, when you are doing some study, you should follow these patients with the NCCT KUB, which will give you exactly what is the stone-free rate. I know you won't do it for routine patients, but for study, that should be the criteria to say the stone-free rate.
Yes, sir. Your point is very valid, but the thing is, sir, as I was saying earlier, the radiation dose that is increased. But as far as study is concerned, we can definitely do a CT. Plus, the people whom we are treating, they come from a rural background, and the money is an issue. So we tend to limit ourselves to USG and X-ray KUB, sir.
Okay. Question from Pankaj. Pankaj, you can unmute yourself here.
One of the major advantages of using thulium fiber laser is you can go to very low joules and higher frequency.
Yes, sir.
What was the need to start with 1 joule and 10 frequency?
Sir, we can. Actually, if we increase the energy, the stone retropulsion rate increases.
Retropulsion is a factor in ureteroscopy, not in PCNL.
Sir,
and that with thulium fiber laser, you can go to lower joules.
Yes, sir.
Means
Okay, fine. We go ahead with the next question. You got it. Pankaj got it. Pranjal, quick question from you.
Pankaj, can I?
Abhay, hold on. Now, next question, Pranjal.
Yeah, don't you think ESWL is a reasonable option in this group of patients? Or the standard criteria of the adult guideline is for the adult patient, not for the pediatric patient, as far as the intervention for the this stone is concerned? What's your opinion?
Sir, according to me, ESWL is definitely a modality, but the problem is if the stone is lower calyceal or if the stone is larger, then the amount of stain tracé increases. And then ultimately you have to subject the patient to another procedure in order to get a complete clearance. Whereas in these using a thulium fiber, the stone fragmentation is much easier and the dusting is very good. So the patient
where do you feel the role of ESWL?
Sir?
Where do you feel the role of ESWL? In which cases of renal stones in pediatric age group?
Sir, normally if the stone is less than 10 mm, if it is a pelvic stone, if it is in the pelvic stone or upper calyceal 10 to 15 mm, then we prefer ESWL. But normally in larger stones or lower calyx, we tend
Last question from Professor Ansari.
So I just wanted to ask, reduction in the caliber of the puncture definitely reduces. This is a known fact over the last 3 decades. But do we know that if we reduce the size of the puncture or the sheath, it increases the intrarenal pressure? It increases chances of sepsis manifold. It is a myth or reality?
Sir, according to in some literature, it is said that the increase in renal pelvic pressure leads to increased pylovenous and pylotubular backflows. But in reality, when in vitro studies were performed in some studies, they didn't find any significant change in the pressure. It was normally below 30 mm of Hg. So according to me, doesn't really make a difference in normal conditions.
Rahul, do we have time?
Definitely ask one question.
Last one question.
15 seconds more.
Yeah.
Can I answer one question?
Yes. Abhay, you go ahead.
Yeah, this is just a reply to Dr. Pankaj's question of joules. So we did all the mini-PERCs in fragmentation mode, and in TFL, thulium fiber laser, the minimum joules in fragmentation is 1 joule.
So if we do go to a dusting mode, then we can reduce the energy significantly. That is the answer to Dr. Pankaj's question.
Okay. So we conclude this presentation. Thank you very much, Arpit. And we move on to the last presentation. Thereafter, we'll be having some time for the some more discussions. So we move to the last presentation, that is from Dr. Shruti Pandit. She is from Kasturba Medical College, Manipal, and she is going to speak on urologist's role in multidisciplinary management of spinal dysraphism. Very interesting topic, and she's mentored by the Dr. Shruti, you tell the name of your Dr. Sunil Pillai, because Dr. Shetty is moved from the KMC. So Shruti, your time starts now.
Good evening. Spinal dysraphism, a congenital defect in the dorsal midline structures, demands different disciplines for its management. And I, Dr. Shruti Pandit from Kasturba Medical College, Manipal, would elaborate on the urological spectrum of the disease. Which is tricky since there is no identifiable correlation between the level of defect and the type of bladder involvement, making it impossible to predict the urological prognosis at birth. Instead, the urodynamic classification, based on different combinations of detrusor and sphincter activity, is more practical for defining the lower urinary tract pathology, with an overactive detrusor and sphincter leading to a highly hostile bladder, putting the upper tract at risk. Therefore, the goals of treatment are first to preserve the renal function and prevent urinary tract infections, followed by addressing the social continence and sexual dysfunction later in life. Of the 126 patients managed at our institute in the last 6 years, 66% presented at birth with a visible meningomyelocele, where the priority is prompt closure. 20% presented in infancy, either due to delayed milestones or cutaneous stigmata, and 14% presented with new onset paraplegia or incontinence due to tethering of spinal cord during their growth spurt. Post-void residue assessment, bladder diary, and Bristol stool chart form an indispensable part of the routine investigations. This spectrum of presentation is similar to the published Indian literature. Now, the most important diagnostic tool to characterize the bladder is a urodynamic study, which we did in 64% of our cases, accompanied by a micturating cystourethrogram with a DMSA reserved to grade and prognosticate the reflux, as done in 21% of our patients. In our urodynamics lab, we perform a cystometrogram with electromyogram in infants and children with a strong suspicion of neurogenic bladder and keep a close follow-up when the findings are suggestive of a high risk of upper tract deterioration. With detrusor sphincter dyssynergia seen in 21% of our cases and neurogenic detrusor overactivity, underactive detrusor, and poorly compliant bladder seen in 26%, 15%, and 23% of our cases respectively. Now, the most time-tested treatment for neurogenic bladder is placement of an indwelling catheter, which has changed little since Franklin and Foley. 9 patients in our cohort were on an indwelling catheter, of which only 5 could be followed up, and all had a catheter-associated urinary tract infection. Now, the Lapids era brought about a seminal change in the management of neurogenic bladder with the introduction of clean intermittent self-catheterization, or CIC, listed as one among the 100 major urological contributions of the 20th century. Now, as impressive as this may sound, considering the socioeconomic background of our patients, we face a unique set of challenges. Of the 68 patients initiated on CIC at our institute, 29 had episodes of difficulty in catheter insertion, either due to hematuria, pain, or bleeding, of which 11 presented with renal failure. This rate of poor patient compliance was much higher than reported world literature, probably because of the lack of knowledge and awareness, despite extensive reinforcement, apart from the other known complications of CIC. Anticholinergics like oxybutynin and tolteridone act by lowering the intravesical pressure and have shown good results in our experience for detrusor overactivity. Patients with a documented reflux are initiated on low-dose antibiotic prophylaxis. Neurogenic bowel involvement aggravates the bladder dysfunction and should be addressed with a dedicated physiotherapy team for pelvic floor exercises and urotherapy to achieve social continence in these children. Intravesical botulinum toxin achieved good results in patients with refractory detrusor overactivity, although high cost and need for repeated injections form important limiting factors. Need for operative management is limited, with 2 patients requiring a mitrophenol for bladder catheterization and 1 requiring augmentation for a poorly compliant bladder. Neuromodulation, auto-augmentation, diversion, and bladder neck procedures are other less commonly used options. Erectile dysfunction and infertility is common in these patients, which can be predicted by the level of lesion. Now, parents with spinal dysraphism should be thoroughly counseled prior to conception regarding the higher incidence of this disease in the offspring, as well as the possibility of pregnancy-related complications. Now, in conclusion, I would like to share our experience with the wide spectrum of presentation of spinal dysraphism with clinically silent disease presenting later in life with catastrophic renal failure seen in 2% of our patients. On the other hand, a patient followed up and counseled since birth with regular bladder drainage, annual urodynamic study, urotherapy, judicious use of anticholinergics, botulinum toxin, and other supportive measures can significantly improve the quality of life in this group of patients. Therefore, the urologist forms an important part of the multidisciplinary team managing such children, which requires much more than just CIC, which is in fact just the beginning of the management, with a lifelong follow-up journey extending from the womb to the tomb. Thank you.
So thank you very much, Shruti, for taking exactly the allotted time only. So we move to the question and answer segment. And Dr. Chandra Singh want to ask you first question. Go ahead, Chandra.
Dr. Shruti, in this group, as you rightly mentioned, there are several permutations and combinations. What do you think is the ideal age to do the first pressure flow studies?
So the ideal age to do, in a patient who is diagnosed at birth with meningomyelocele and is repaired, we must do the first urodynamic at 2 or 3 months of age once the period of spinal shock has recovered. But obviously those patients who present later in life, where we must do a urodynamic at the first suspicion of a neurogenic bladder.
Pramod, are you there? This subject is very close to your heart. You can go ahead with the question. Pramod. Okay, then we move to the Dr. Ansari. Dr. Ansari, you put a question. Unmute yourself, sir.
Counseling is very important in these children. When an operated child with meningomyelocele or spinal dysraphism comes, so how do you counsel? How many percentage will improve? How many will remain stable? How many will deteriorate?
So as per what we have experienced over the last 6 years, almost 27% have developed renal failure. As I highlighted, one of the most common complications is not adhering to treatment like CIC. Those patients who have not adhered to CIC have presented with renal failure. So when a child presents with meningomyelocele, it has to be, as I stressed, it should be multidisciplinary. There should be counsel from birth that they have to keep on a long-term follow-up, and they have to stick to they have to stick to a good CIC practice. We must make sure that they are following the CIC correctly. That is, I think, one of the main counseling which we give as a urologist. And
Okay,
apart
Dr.
from
Paul.
CIC, we must give them other options as well, sir.
Dr. Paul.
Just a comment, it's a great presentation. I think one of the things that I preach is that those kids are born with normal kidneys. So once they get into renal failure, it's the failure of our systems of healthcare in treating those patients. And you've got to be extremely aggressive in those kids. And even if they are not compliant with CIC, really taking aggressive measures, or even creating vesicostomies to prevent the consequence of renal failure. I think we're failing those patients by getting them to renal failure.
Okay.
Yes.
Yeah, Shruti, you can say.
Yes, sir. What you're saying is absolutely right, sir. But the thing is that we face a different scenario of socioeconomic background in our country, with many patients who may not follow up, who know there's a poor prognosis since birth, opt not to go for surgery. As I mentioned, 5 patients went with an indwelling catheter. Those were the patients who were quadriplegic, who were poor prognosis, poor financial background. So all these are some limitations which we have in managing these patients, sir.
A quick question from the Luis.
Question number 1 is that how reliable is the urodynamic study in the 3 to 6 month age babies? And then also, do you have any tricks, or how do you adjust when you have patients with bilateral vascular urethral reflux, and how can you measure the real compliance of the bladder in those patients?
Sir, answering the first question, there have not been any well-defined cutoff criteria for urodynamics in such small infants, but at least we can have an idea of whether there are any signs, danger signs of upper tract damage like DSD or high detrusor pressures. Answering the second question, sir, we always combine a urodynamic with a micturating cystourethrogram to check for whether there is any reflux, because when we are doing a urodynamic in the presence of a reflux, we can underestimate the compliance due to the pop-off mechanism.
Any method you can make sure that you are obstructing the refluxing urine to get the best possible idea? Okay, Hemant Pathak sir, last question from you. Unmute yourself, sir. Unmute, yeah, sir.
You have significant number with occult spina bifida. What was the age of presentation?
So occult spina bifida presents anywhere from after the first month up to, we have seen, as I put up, a 16-year-old girl who presented with renal failure. So that is the range of our presentation, sir.
Okay, fine.
Okay. Rahul, do we have a time or we finished?
Sir, we can ask one question more.
One question quickly from Malik. Malik, you have interest in this area. Malik, you can ask the question.
Shruti, the only issue which I actually look at all your presentation is, I think I fully agree with Dr. Paul that we need to start our treatments very early. That is number one. And number two is, I wouldn't agree on that because of the socio-economic backgrounds, these children would not undergo surgery. We were also doing a good number of mitrophenops or augments. It is how we talk to them and what we tell them and what we actually prognosticate. Because aggressive I am a proponent of an aggressive.
Malik, she got a question. Suti, you respond. Why you have a more CIC convinced patient and maintaining the function, and why don't have a mitrophenop and augmentations or augmentation and mitrophenop together, which is more or less seen in most of the series?
My question is, would you advocate a wait and watch policy in your treatment of the neurogenic bladders, or are you going to do a proactive management in these cases with children?
So as per the latest literature, proactive management has found to have better long-term outcomes with better preservation of renal function, which is what we advocate rather than expectant management.
Okay. So, Rahul. Okay. So, thank you very much, Shruti.
Thank you, sir.
And I request judges to put the marks for all 8 presentations. I hope they have marked already 7 presentations. You can go ahead with the marking of 8th presentation and send it to me, or if you have a number of Dr. Kesamurthy, you can directly send to them. And this is now precisely 8:45, at least in my watch. We have a 15 minutes, and during that, at least 7 minutes we give to the judges to compile the results. During that, Dr. Kesamurthy, if you feel that we can start most of the concluding activities, so we can finish everything in time. Professor Kesamurthy.
No, I think while the judges are marking, you can continue with your discussion.
Okay, fine. So we have another 5 minutes, and I don't know whether I will be able to give you more room for the discussion, but before that, once again, from bottom of our hearts, all Pediatric Urology Committee, myself, Dr. Mallikarjun, Dr. Rahul, Dr. Chatterjee, and Dr. Prasanna, we are extremely thankful to our presenters first, because they have put a lot of efforts. All 33 presenters congratulate you and thank you very much to be part of this exciting contest. We learn a lot from you and your mentors. Secondly, I'm extremely thankful to my experts, those who have come every day whenever we called in last five sessions, and they have really nicely interacted with our presenters. They have taught many lessons to us, and we learned a lot from you all, sir, all experts. Thank you very much being with us, specifically Luis Praga, Professor Marguren, and Professor Reddy for coming again and again. and our also all international faculties contributing this much of time enlightening our students. Our aim were to start with showcase skills in the field of pediatric urology from across the India, and probably I am sure our dignitaries, our office bearer will agree that we are most successful in doing so. So, second, our aim was we can see that how further we can improve in our understanding of these diseases, management, investigations and management. So we'll come to know from our experts and the USI Secretary, President, ISU Officer Bear, how far we have succeeded. But to my mind, we have really succeeded into achieving these two aims. And the last one is that, we fought this corona with a lot of strength. I hope God gives you courage to withstand the more onslaughts are coming from this COVID. And two lessons we learn: melt our ego, believe in brotherhood beyond the boundaries, and humility. With that, I sum up my words, and I don't know to whom I hand over, but Murthy sir or Dr. Chawla, you can go ahead with this. I will come again once the results are out. Thank you very much.
Chawla can do his concluding remarks now before we move on to the results and the closing remarks by Professor Sood. Chawla, over to you.
Okay, sir. Okay, I'm here only, sir. Just 1 minute. I was just sitting, watching the whole proceedings and just writing down. Can you see my slides, sir? Hello?
No, we are not able to see you.
No,
see your slides.
Now?
Yes. Yeah.
Yeah. So, amazing event and academically productive Sunday evening. The grand event of pediatric urology subspecialty coming to end with today's program. A total of 32 presentations from zonal rounds to this finale from the regents backed by their mentors. And I believe that all the regents had excellent presentations, sharing with their experience of institutions and the centers where they work. What we conclude from the whole competition, right from the rounds to the finale, that we have diverse themes and topics. We had the 8 presentations from the area of reconstruction, the Epispadias, the Epispadias, the bladder neck reconstruction, and others. And the second most commonly covered theme was the PUJ obstruction. We had 3 on the evaluation and 2 had on the surgical management. The procedural valve also was another important theme, which had 4 presentations. Oncology was 3, and the stones was covered by the 2 presentations. And others were on the varying themes of anuresis, reimplantation, and of course, renal transplantation also found in this competition. What we saw was from the last year's edition of this pediatric urology subspecialty program and this year's, everything was different. There were newer topics, newer themes. And what we see from this competition is that a lot of pediatric urology work is being carried by different centers and the institutions, but it is getting unnoticed. There's not much being published into the various journals. So it's not the right way to wait for another year, another competition to come with a newer themes and newer topics, but probably it's the time to look inwards, and it's the era of teamwork, it's the era of collaborations. Probably we need to forge multi-institutional collaborations or the team collaborations where we can do a good quality prospective work with a good follow-up, and this work can get published into good journals and established our work in the international platform. And I think the USA and the ISU encourages and urges all the mentors to look into this. I think every competition needs high quality and critical comments to reach the standards of high quality. And this program, including the rounds and the finale, had experts from the from the national faculty as well as the international faculty who were asking questions which were very pertinent, and probably some of the questions were carrying some sort of pearls and wisdom and the take-home messages. Let me place on record the special thanks to international faculty, Professor Pramod Reddy, Luis Braga, and Paul for being with us in today's final event, as well as thanks to the national faculty. I think as we discussed in the yesterday's dry run, all the 8 postgraduates, the residents are the winners, no matter what is the result which is announced by Dr. Keshamurthy, and that will be just a formality for us. All the 8 residents are something like a winners, and our congratulations in advance to all of you. Many thanks to and appreciations to the team of Pediatric Urology Subspecialty headed by Anil Tekwani. Yesterday when we were having dry run, he was not sure whether he will be making his presence in today's program because one of his relative was not, he was sick, but he was there and thick and thin, he was there in today's program. And our sincere appreciation to him as well as his team for the hard work done from the conception to the completion. And in the end, thanks to all the faculty, the mentors, the experts involved in today's program. Thanks to the central office of USI, Navneet and Kiran for providing all the logistics support. Thanks to all the viewers for watching this program in good numbers. Last but not least, very important to stay safe and stay well and stay healthy. Thank you very much.
Professor Sood, you can give your remarks. We are collating the results.
Okay, so Dr. Keshav, Dr. Arun Chawla has wonderfully concluded the whole thing. This was indeed very well conducted competition. The subspecialty of pediatric urology has been growing and has shown that all the zones in India, all over India, what all is happening, it is a beautiful exposition of the work which is going on and how in future the collaboration can be there. All the experts and all the teachers and the presenters who participated have done wonderful job, and therefore if such high level interactions continue in the subspecialties of urology, we are on the right path of creating really worth its goal, the Indian School of Urology, and the heights which we are reaching in this pandemic pandemic of COVID regarding our education. In spite of that, or in spite of the hard space, in spite of all of us who are involved in the work, day-to-day work regarding COVID, we have forgotten what we were doing in urological work in our hospitals, institutions. All have concentrated in saving the mankind, humanity, and in this all, we are not forgetting the furthering the cause of urological education, and especially furthering the pediatric urology subspecialty, reaching new heights. Dr. Anil Tekwani is really to be congratulated for this wonderful work, and which has been possible with all the members of pediatric subspecialty. I think all the competitors are waiting. They are awaiting the results, and Dr. Keshav Murthy will be coming, but I congratulate before that each and everybody who participated. All the 5 sessions of this program were wonderfully conducted and are worth a treasure in our Urological Society's archives. I hand now this back to Dr.
Yeah, thank you, sir. Thank you very much, Sud sir. Dr. Kesamurthy, you have now remaining mark sheet is also there with in your WhatsApp. Please check. Please check. I have sent it. Are you able to open it up? You have to unmute yourself, sir.
Anil, I am just adding the marks now.
But you got it, no?
Yeah, I've got all of them.
Which one?
I've got all the 5 judges' marks.
Okay, fine.
I'm adding
fine. Thank you. So you just, I know that's a little time-consuming task. For that, we have some time.
Yeah.
Comments from our international guests, Dr. Braga and Dr. Paul, if he's there. Yeah, both are there. Reddy was having some operative call because he's today on a call till he joined. So Luis, you can go ahead with the comment. Our presenters mainly.
Yes, very quickly. So as I mentioned on my comments to post message to everyone, I think this was a well-organized contest. I think I was very impressed with the high level of the presentations and the discussion. So I congratulate you and all the organizers and the Society of Urology in India, because this is a great thing for the trainees to be engaged and motivated to do a good job and present. And again, it's always a pleasure to participate here. And then I see often Dr. Megarian and Dr. Reddy and Dr. Asim Shukla, they are all in this presentation. So this will, of course, enrich the discussion. So it's a pleasure, and I wish you guys all the best of luck. And then our feelings for this difficult situation with COVID in India, as it is in Canada. We're in full lockdown here in Ontario. So thank you, and then hopefully we can get through this soon.
Thank you, Luis. We'll definitely come back to you for our global webinar. And at that time, we'll try to get more time from our secretary. I promise you. And second, regarding the Asim wanted to join. He has sent his best wishes to our presenters in this contest. He's traveling right now from California to the Philadelphia. So that's the reason he could not join. Quick comment from Professor Paul Margaran regarding these presentations and the contest.
I'd like to congratulate all of you for a superb presentation. I think the topics were relevant. They were very well discussed. Every single one of the presentations, it was really hard to score them because every one of them was superb. I'm really glad to see how pediatric urology has advanced in India you all provide really high quality care to your pediatric patients. And again, my prayers are with all of you. I hope this pandemic will end soon and we'll be able to see each other in Ahmedabad in January 2022.
Thank you. And we would like to take your promise. Join us on global webinar, which you cannot attend and participate in last year because of some specific reasons. And Luis, you have to promise us that we want you to get a promise to bring Pipi Saleh and the Tony Quick, both of your say the mentors or inspirations.
Yes.
So I'm sure I'm working. Pipi Saleh promised.
So just give me the dates in advance, and I can promise you that they will come.
We'll definitely start talking with.
Hello. I'm sure Dr. Paul Margarian can twist Dr. Kuri's arm to come as well.
They're both good friends of mine, so I can talk to them.
Hello. Anil?
We can hear you, sir. We can hear you.
Okay. Is Anil there?
I think Anil sir has means his video is frozen.
Not seen, sir. Now maybe connectivity issue.
Hello.
Go ahead, sir. Go ahead.
Let me congratulate Anil Takwani for conducting this Pediatric Urology Subspeciality webinar, which was an interzonal competition in which 24 institutions from all over India had participated. And today we had 8 very well documented and presented very nicely by the presenters and the mentors. I congratulate all of them who have taken part in this competition. And we have the results with us. I would announce the first 3 results. And I would take pleasure in announcing that I took a special grant from academic grant, and I'm announcing that the first prize would get 25,000, the second prize person would get 15,000, and the third prize person would get 10,000. This is to promote your pediatric urology. We would not, this is a one-time one. I would not offer this to all the subspecialties, because then it would mean a lot of money to the USI. So it's only for promoting pediatric urology subspecialty. The first prize goes to Zain Tomboli from SGPGI, and the second prize is to Punit Kumar, and the third prize to Shruti Pandit. These are the 1, 2, and 3. All of them done well. The first two, 1, 2, and 3 are very close. They are very close. So 1, 2, and 3 are very close, and it was a very tight fight.
Can you repeat again the 1, 2, 3? Because I'm just trying to write down for my list here. So I put just the initials.
Dr. Zain Tamboli was the first prize.
Perfect.
Dr. Punit Kumar was the second prize, and Dr. Shruti Pandit was the third prize.
Excellent. Congratulations to all.
Can I have Dr. Kesavamurthy,
Congratulations to
one
all.
comment which I probably could not make? The beauty of this contest is that all these judges were independent, and they put their marks, and this were directly forwarded to Dr. Kesavamurthy to calculate the final outcome. And I'm sure that all of you will accept the whatever outcomes with the broad heart, and wish you all the best. I could not get your comment, Dr. Kesavamurthy, but our points were Pediatric Urology Committee decided to promote the residents to come on such a huge platform, and thanks to you and the USI ISU that you allowed us to carry out this contest in benefit of our residents and junior consultants. Thank you very much, sir.
Yeah, thank you, Anil, for a wonderful webinar, which was I have sat through all the presentations. They were all high-class presentations. Not only the finals, even the interzonal ones are also very good presentation, but we cannot get all of them. So the best 8 was selected for this. And I thank all the pediatric urology subspecialty members for putting this together. It was good. Congrats to all of you.
And these 3 will go to the directly in global pediatric webinar, which we are going to organize with the help of secretary. We'll decide the dates little later on. And the second thing, sir, all are expecting, as we promised, the certificate of participation. Sir,
Anil, I thought you didn't hear.
E-certificate, when they can expect?
No, Anil, you probably did not hear. It's not only certificate. I have given 25,000 to the first person, 15,000 second, and 10,000 to the third person.
Thank you very much, sir. And certificate to all participants, no, sir?
Yeah, that
all participants will get the certificate.
The Indian School of Urology is always giving the certificates, but you want it to for all the participants, that will be done.
Sir, we promised in the beginning that they will get at least a certificate of participation, as they have contributed their lot of strength in spite of this adverse our conditions.
That will be done. We will send the certificates to all.
Thank you. I will send you the complete list once again to all office peers.
That is fine.
Thank you, Anil. Thanks to all of them for joining in. Thank you.
Thank you, sir. Goodbye. Good night, sir. Stay safe. Stay well.
Congratulations, Anil, and all the winners too. Congratulations.
Okay.
Thank you. Thank you to join.